we will continue. So let us start. We talked a little bit about this last time, the history taking template, but I'll just go over it really quickly. You have a question? Let me see before we get into it. Yes, hearing. Okay, good. That's perfect. Okay, so just remember the history taking template. One big thing I've noticed in the NHS clinics is when people go in and meet a patient, they do not take a good history. So they just jump to the complaint and then they start figuring out the differentials instead of first focusing on that complaint, that chief complaint. And I mentioned it before, and I think also in my other sessions about using old cut when you are having a patient who's saying, I'm having pain, or I have, a rash. You want to find out the onset, the location, duration, characteristics, alleviating symptoms, aggravating, associated, radiation to any other body part or treatment. Your differentials also come in, but don't ask too many differentials. Honestly, find out the main ones and then keep moving. Don't forget your past medical history, hospital, surgery, all the good stuff. Now, as per, different reports that I've had, when you say, I would like to do a physical examination on a patient, the patient will just start to undress, and fairly so. So it's much better for you to anticipate that an examination may occur even though you're not being told that there is an examination, okay? So a patient may have chest pain, and then you go in, you do your differentials, you ask your questions, and you say, I'd like to listen to your lung sounds. Expect them to, start undressing. So just tell them, I'd like you to expose from your shoulder all the way maybe to the mid-chest, or from the mid-chest to the waist. But make sure you tell them what you want them to expose. Anything that may be a bit, a violation of their privacy, or they're not too uncomfortable with, you may want to not have a chaperone. But if you feel that a chaperone is needed, you have to ask for one. Remember, in the 2-minute bell, you're either telling them they're going to be admitted, they're going to go for observation, they're going home, but give them direction. Okay, just a quick overview there. Remember about the past, the present, and the future. You have to find out what happened before the disease, the current presentation, and always give the patient information so that they don't have to keep coming back with the same presentations of the disease. Always educate that patient. So some of the things I mentioned last time about finding about the past. Screening is so important in this country. So breast screening, cervical screening, colon cancer screening. Okay, ask them, when was your last pap smear? Do you do breast exams every month? Have you noticed any differences with how your health was before you came in for the visit and now? Okay, is the doctor following you for any medical conditions? Any troubles with your cholesterol, high blood pressure? Just something very easy. That way you're not just very rigid in asking about, do you have hypertension? Do you have diabetes? Okay. Ask them how they're maintaining their good health, right? Any recent stress or events that have led to the symptoms is also very important. So now a patient can say, I have a headache, but their concern is not the headache. Their concern could be, I have a tumor. So you have to ask, what is the complaint and what is the concern? Don't let your patient leave without you finding, how they have been coping with this condition. Is it affecting your lifestyle, your family, your work, your relationships? Do you have any good support right now? Okay. How has it influenced your sleeping pattern, your appetite? Okay. I talked about examination a few minutes ago, but here, examination starts before, management will start before 2 minutes. And if you're having a hard time in managing a patient with a short amount of time, think about action. You need to do something. A to H. You're admitting, blood work. Remember the FY2 deals with all type of blood work, non-invasive, okay? Like really big procedures like a lumbar puncture. We're not responsible for that. But your basic full blood count, urea and electrolytes, LFTs, RFTs, you should not miss. ABGs, random blood sugar, okay? And sometimes if you really don't know what's going on with the patient, you might as well just say, throw a net to them and say, I'm just going to check all these bloods. and see what we can figure out. We also can order MRIs, ECGs, ultrasounds. Okay, if you're really concerned about your management, get review from a consultant or a senior. You want to refer people who are outside our scope of practice, so GI, neuro, cardio, and then you can say what they might do. Neuro may consider a surgical intervention. GI may consider colonoscopy. Psych may do some talking therapy and give you some antidepressants. And then if they're going to go home, you have to tell them, watch for this, this, and this. Don't spend too much time talking about emergency signs. Just one or two things in relation to what they came in with. Anybody who has a referral, you want to say in the end, can I call you in a couple of days to see how you're doing? Or when you're done with your referral, please make an appointment with us. Okay, we would like to follow up on what the dermatologist said. Okay, give your leaflets, give your documentation, give hope. Some of them really think that, that small little wart is cancer, and maybe it's just a papilloma. Tell them there's a range, it depends on the results of the biopsy. So it could be just something very benign, like an accumulation of tissues, or it could be something sinister. So let's find out from the biopsy. We just don't go about telling patients that they have cancer because, it looks like, the area is raised, or they have, skin changes and weight loss. Even though we have a gut feeling that they might be dealing with cancer, you want to land on that spectrum. That way you don't get into trouble. We have to have a biopsy pathologist report in order for us to give that diagnosis. Okay. Then when they go home, think about them. What do they need? Do they need social services? Do they need a job? Do they need to report their condition to the Department of Motor Vehicles? Okay. Do they need an allergy bracelet, especially if they're a child and they're in a population where they have a peanut allergy and they are at risk for anaphylaxis? Do they need epinephrine to be in their school backpack? Okay, if they are diabetic and they're having a hard time maintaining their blood sugar, can we have a visiting nurse go and visit them and teach them how to use their glucometer, or a carer? Okay, so these are some of the things that we have to really remember in the end. We talked a little bit about breaking bad news to a patient, and there are two different templates. I don't know if I mentioned this last time to you. If the patient is calm, by all means, gather history as to why they came in the first place. So you're going to introduce yourself. My name is Dr. X. Okay, are you Samantha Jones? Are you here by yourself? Who did you come with? Who dropped you off? This is important to ask earlier on so that you're not making them too afraid before you break the news. Okay, make sure you confirm the name and age of all patients. Okay, and then find a bit about the past history. So you had headaches. For how long? The location, the duration, the characteristics. And how about now? Is it worse? What have you done in between then and now? How are you coping? Do you have any family assistance? So they may have a tumor or a massive intracranial bleed, or their father may have had a stroke. So you want to find out this information even from the family. And when you're breaking the news, you want to break it in layers. So there's a traditional way of breaking bad news, but now there's a little bit much better modified way that I use. So I always start by presentations from the door. Your father came in with a headache. Okay, we were concerned about it. We did some scans. All right, the doctors have even done other investigations, and unfortunately, the scans show that he has a massive tumor, or he has a bleed in an area of the brain. Okay, or unfortunately, they have a stroke. And then you wait. Let them absorb. Count your seconds. You don't want to keep rushing. If it's something like a cancer that is, a cancer in situ that is not yet malignant, don't water it down. Don't say, don't worry, we can deal with this. We see this all the time. We see people with HIV all the time. People with HIV live long lives. No, let them absorb their news. Don't tell them not to worry. At this point, then you can say, do you want us to call anyone for you? All right. I can wait with you as your family members come in, or you can use our phones to give them a call. This is challenging news. So don't say, I can understand, I don't worry, which is another, some really bad, diluted phrases that people use. Look at what they are doing. If you see them crying, offer them some tissue. You can move your chair closer to them. But sometimes proximity really is a little bit tricky in this country. You may not want to be the doctor who's going to hug the patient and tell them, oh, don't worry, Mrs. Jones, I'm here for you. Okay. So the doctor support and compassion comes more through the words that you're saying. We are here for you. I'm part of a great team that, we have a good support system. We have counselors on board who can talk to you and give you some coping skills on how to deal with your condition. We can refer you to support groups in the community. Okay. Then there's the other patient who comes in and they do not want to sit down. They're walking around pacing. They're just saying, give me my news, give me my lab reports. I want to know what's going on. You still have to introduce yourself. I'm Dr. X. Can I please know who you are? Did you come in with anybody? All right. If they pressurize you to break the news, the first time they pressurize you, just say, it's important for me to know a little bit about your history. It's going to help me manage, or it will help me make a better management plan for you. Or can I ask you at least 2 questions about your presentation? And then you have to choose the questions very carefully. So you wouldn't just do a review of systems, okay? But if they keep pressurizing you, don't fight. Don't say, no, let me tell you. No, doctor, I want to know. But let me tell you, please. Let me ask you a few more questions. No, you can make them into an angry patient, and then now you've lost you've lost even the communication that you've built up with this patient. Now they say, no, I want to know my results. Then you tell them, so you came in on what day? I came in 2 weeks ago. We drew your blood. Again, I'm really trying to extend it. We drew your blood. We took it to the lab. Okay. We did a couple of tests with it. And if it's like the HIV test, which I'll discuss in a few minutes, we checked your blood work. The Western blot was positive. We checked a viral load, which just checks the amount of virus in your blood. And unfortunately, it is positive. You are HIV positive. You have to say you have cancer, or you have squamous cell carcinoma. So give them the exact report that the pathologist has written. Then you stop and wait again. Okay. You first offer yourself as support and say, I am here for you. Take as much time as you need. Can I call anybody for you? All right. And then it's more of a patient-centered approach, whereas you can't start talking about treatment and they're still crying about the news. Okay. You have to walk hand in hand in them. I can see that this is challenging news for you, Mrs. Smith. I can see that this is, hard for you to bear. Please do not be too disheartened. Okay. We are here for you. There is treatment. May I continue? Or you can say, can I tell you what we are going to do next? Okay. And then give it to them in small doses. What the doctors are doing now, we have support teams, we have counselors on board, we have a psychiatrist. Okay. And then after this, you can get a past medical history if the patient is calm. All right. Then you can say, so when did you start noticing these symptoms? Was your health always was your health always like this? Or was there a period in your life where you were healthy? When did you start noticing the decline? You have to gather data from all your patients. You have to manage the data that you've collected and just add your interpersonal skills as a little bit of salt. Okay, so breaking bad news, you'll find so many different cases in the NHS: cancer, HIV, serious accidents, surgical complications, death of a relative, miscarriages. I think I talked about a life-changing injury, be it a child who has had an accident or a loved one, someone's husband who was in a car accident and the relatives are there. You want to try and have them sit down in a private area Make sure you introduce yourself. They may try and get information. Is he dead? Is he living? What is happening? Have you seen him? Does he have a bruise on his head? Will he live again? Try and will he live a normal life? You have to try and calm them down. You cannot also be anxious and they're also anxious, okay? Give them compassion. And how do you give them compassion? You cannot give them false reassurance, all right? You have to stay within the boundaries of the information that you have. So if the only information you have is that, we have, as per now, the doctor has, amputated the leg, okay? Or as per now, the note says that his leg has suffered an amputation below the knee, and I'm really sorry to tell you this, you stop and wait. Or I'm sorry, he's had a severe brain injury, okay? And then now, after that, then you can say, let me get the seniors. Let me get the consultant who will give you elaborate details on what they are doing, okay? Once he is stable, I can come back and we can all go and see him together. Do you want to call your family members, right? And then the future is where most people get trapped up with cases that they're asking, is he going to live? Is he going to walk again? Do I need to change my whole life because of, my husband's injury? We always hope for the best. And it may sound like a cliche answer, but we are hoping for the best. Regardless of the outcome, we are here to support you. So you're covering them in death and in life. We are here. Or if they need a lot of support to recover, or because of his injuries, he may have a challenging recovery process. We are here. We have physical therapists, occupational therapy, okay? If he's having trouble from the massive stroke that he had, even speech therapy can be involved, and not only is there support for him, there's support for families who are dealing with such traumatic cases. So that's where I want people to end when they're talking about that. All right, let's talk about this case. We didn't talk about it last time. I do have my water that I like to drink from time to time. Now, a miscarriage is a breaking bad news. Okay, you never want to just walk in and just tell a woman that she's having a miscarriage. She may have an inkling that, everything is not okay with the baby, but you want to also break it down in layers. So, for example, the nurse comes and tells you that, we have a woman here. She is, 18 weeks pregnant. Her name is Samantha Jones. She is coming with some abdominal pain and also some vaginal bleeding. So you go in. Hello, Samantha. My name is Dr. X. I'm one of the junior doctors in this department. And if she's looking really sad, of course, you acknowledge that. Acknowledge the non-verbal body language first, okay? Because sometimes the patient can be like, I'm doing okay, but they are really not. The words and the body is not matching. So you can say, I can see that you are looking a bit disheartened, or you're looking sad. Do you want to talk about it? I'm here. My name is Dr. X. And if she doesn't want to say anything, or she's just very, very sad, you don't want to pressurize her. You can always use the medical note and say, Samantha, the nurse told me that you've been having some stomach pain. When did it start? Old cut, onset, the location, duration, characteristics, everything right through. So she may say, I'm having a bit of cramping or pain in my lower abdomen. For how long? How bad is it? Find out, is she in pain now? Doctor, I'm in pain. Have you taken any medication for it? What did you take? And when was the last time you took medicine? We can't just say, I want to now offer you pain medicine, and you haven't found out that she's just taken it 15 minutes ago. You may want to tell her, do you want to wait for a couple of minutes to see the effects of that medicine? Okay, before you start bombarding them with morphine, and they say they just took some medicine a few minutes ago. Okay, so then you find out, in such a case, you never just want to say, I see from my medical note you have vaginal bleeding. No, that's too harsh. Start with non-invasive and then get into like the sticky stuff. So tell me about the vaginal bleeding, Samantha. When did it start? Again, you old cut the information. And with all vaginal bleeding, you want to ask them, how many sanitary towels have you been using in the last 1 hour? Have you seen any blood clots? Okay. Are you bleeding from anywhere else? Okay. And then now you can, because it's abdominal pain, vaginal bleeding, you're talking about the vaginal area. I would ask a little bit more about, the more invasive questions. I would find out, okay, is this the first time that it has happened? Okay. Do you have a partner? Okay. And then, so I'm going towards sexual history, and I don't want to just ask, are you pregnant? Do you have a partner? Are you sexually active? And then any chance that you may be pregnant. Then she'll tell you, yes, I'm pregnant. I'm 23 weeks or 18 weeks or 8 weeks. Okay. Before you tell anybody, congratulations on your pregnancy, read them. Some people are pregnant and they do not want to be, or they are having a hard time accepting it. So just, you may ask her, is it a planned pregnancy? Yes, it is, doctor. Okay, do you have any support? Did you want me to wait for your husband to come in for this visit, or do you want me to still continue with my assessment? It's okay, doctor, you can still continue. All right. Now the thing is, a pregnant woman who is coming in with abdominal pain, vaginal bleeding, you still want to find out safety in the home, because there are very many cases of women coming into the hospital and they've been abused, okay, by their spouses or whoever may be living with them in the home. You want to ask, is your husband supportive? Yes. Do you feel safe in the home? Okay. For non-accidental injury, that's what I have here, non-accidental injury. Okay. Now you say you have, even now, if she has told you that she has been having the vaginal bleeding and she's soaking maybe 10 to 15 sanitary pads in the last 1 hour, you would have to stop that question interrogating and say, I'd like to check your vital signs, and maybe even put 2 large bore IV cannulas in you and start giving you some fluids. So you never hear of an alarm presentation and then continue asking about whether they've been traveling and whether they like Bobo the dog. No, you have to be able to adapt. Okay, so it's 5 to 6 sanitary towels. Do you feel dizzy right now? Do you feel like you're weak? Okay, then I want to check your vital signs. I want to at least get the nurse to put a large bore IV cannula. We may have to keep you here to find out the cause of the bleeding. But because you told me you are pregnant, okay, sometimes bleeding in pregnancy, especially early pregnancy, is, a slight concern for us. It could be normal, but heavy bleeding with clots is of a large concern to us. Okay, I'm not saying that the baby is dying, so don't start saying you may have a miscarriage, you may have an ectopic pregnancy. No, let's do our investigations first. We will let the consultant know. We may even need to get an urgent referral from the OBGYN on call. I'll get the ultrasound. We'll see first how the baby is with the ultrasound, okay, the positioning, the amount of the fluid around the baby, okay. We'll also send some lab work for you to make sure your blood is not, you're not anemic, or you're not losing too much of your clotting, or your clotting imbalance, to check if you have a clotting imbalance also. And then once you say that I will do an ultrasound, and you can even confirm the pregnancy. If she's visibly pregnant, that's fine. Somebody who's not visibly pregnant, I would just say, I would like to make sure that that you are pregnant, and do a beta HCG. So now, if the results come back that the patient has an ectopic pregnancy, or it says that there is no fetal heart sound during the CTG or something. So you get those results while you're sitting in front of the patient. You just cannot blurt out that news. You have to start it, maybe breaking it down. You may have to say, Samantha, we have checked your uterus. We have checked the status of the baby, and we can see that the pregnancy is not growing in the right place. This is called an ectopic pregnancy. Give them, count it out, because sometimes we talk too fast and we do not know that we are rushing the patient. So count your 3 seconds, 4 seconds. Okay, I will need to do further testing to make sure that the pregnancy hormones are at an appropriate level, but usually a pregnancy that is not developing in the right area will not be able to continue to grow until term. Okay, give her time to absorb it. So, doctor, what do you mean? You mean my baby is dying? Now, the thing is, if she's calling the baby, the pregnancy baby, you have to call it what she's calling it. Some people have gotten into big problems saying, no, it's just a bunch of cells. They just got trapped on the way from the fallopian tubes to the uterus, And besides, you have another fallopian tube on this other side. You can always get another baby. I had somebody say that. And I said, wow, that's really bad. Okay. So you want to take it with her nice and easy. She may say things like, please, can you just help the baby, push the baby down into the uterus? Please just try and preserve the baby. Can you transplant the baby from my fallopian tubes to my uterus? Unfortunately, we do not have the capacity to do this. And this may even compromise you further if the pregnancy is allowed to develop in this section. Okay, it is important for us now to have you see a OBGYN doctor. They will do serial blood tests to check the hormones of the pregnancy. If the hormones are not reducing, then they will need to give you some medication to help the pregnancy pass, or to help the pregnancy tissue pass on its own. For example, methotrexate. But these cases need so much compassion. Do you want us to call anyone for you? If you need some time off work, we can even provide a sick note for you. We can organize some time off for you, just to be able to to process what has just happened. The same thing with a miscarriage. Okay, in fact, because you've already found out she's having a miscarriage, you may want to ask a little bit more information in the end. Is this the first time you've been pregnant? Or you could have asked this in the beginning, actually. Is this the first time you've been pregnant? Do you have any children at home? Have you had any pregnancies that did not make it to term? And then now, if this is a frequent thing, then you'll have to add a few more labs for her to make sure that she doesn't have any genetic problems. Okay, a new diagnosis of HIV. What is important for a patient to know in HIV? You want to make sure that this patient will be safe when you tell them to go home. So you have to gauge them. If they are very frantic, walking around the room after you've told them the news about the HIV, you may want to tell them, it might be better for you to just spend a couple of more hours here. Let's talk to you about this diagnosis and even show you how it is a manageable disease. Okay, can you please call somebody to come and pick you up? I would not want you to be driving home. Okay, take some time off work. Okay, let's first get to the basis of this diagnosis and how we can you can cope with it and live a healthy life in the future. Okay, so now here is the guy. He comes in, doctor, I want to know what's my result. Okay, and then you tell him, it's important for me to know what brought you into the hospital in the first place. I had a rash, I was coughing, I had a bit of weight loss. Okay, and then now the worst thing you can ever ask somebody who either has a positive result for HIV is to say, so what is your main concern this visit? Wow, his main concern is HIV. Okay, so that question of concern and the way people use ICE, ideas, concerns, and expectations, no, you have to be very, very careful, because it's going to ruin your communication between you and the patient. Okay, so you start off. When you came into the clinic, we took your blood, tested it, confirmed it twice. Unfortunately, you are HIV positive. You never say, unfortunately, I have bad news, and then you keep quiet. It's a 50-50 chance. Bad news, HIV. Good news, you don't. Okay, I'm really sorry. You are HIV positive. Let him absorb. I can see, Samuel, this is very challenging news for you. I am here for you. I can give you as much time as you need. Is there anybody you would like to call? Our main concern is to keep your immunity level high and the level of the infection low. This is done with the use of medication. So some people want to start, there's NNRTIs, there's all this other stuff, ritonavir, and he'll not even remember that. But he will remember if you tell him the most important thing is to keep your immunity up and to keep your, the level of virus low. It is important for us to start medications as soon as possible. Then you wait. Is it okay for me to continue, James? Yes. When your immunity is low, you are at risk of opportunistic infections, which are other common conditions that would not have attacked your system if your immunity was high. Excuse me. This is our aim of starting treatment. Okay, and then they may have a bit of where most people also have a hard time is what happens to a patient after you give them a diagnosis in the GP's clinic. There are specialties, so any HIV, gonorrhea, syphilis, chlamydia, all those go to the GUM clinic, the genital urinary medicine clinic. We don't say GAM, we say GUM. Okay, he can go to the HIV clinic where they will speak to him about different therapies that he'll need to use, and according to the way he's responding to the treatment, they may be able to titrate the medication for his specification. Okay, we can do a few checks to make sure his blood count is okay, his kidneys are working fine, his liver is working okay, but you want to walk with him. And before you move on to the next place, ask him, may I continue? Right? And you mentioned to me, James, that you do have a wife at home and you are not you are sexually active, but you do not use any protection. It is important that we also check to make sure that she does not have the virus. Now he'll fight. He may fight. He may say, "Doctor, please don't tell my wife that I have HIV." No, we will not tell her that you have HIV. We will tell her that she may have been exposed. You will be kept anonymous. And in fact, this is done at the GUM clinic. They have the partner notification program where they will notify all the people you have had sexual intercourse with in the last 6 to 8 months, and they will tell them that you may have been exposed to an infection. Please come in for testing. They will not disclose any information about you. But the best thing would be to talk to your wife about it, okay? And you can even bring her in into the next visit and we can test and make sure. That way, if she has the infection, we will start her on some medications. We are here to support you. Of course, we don't say that you're going to live long. That's why I have it here in my notes so that I remember not to say it. He may say, "Doctor, it's a death sentence. It's I'm doomed. I'm done." You have to investigate. So why are you saying these words? With such a condition, it will be a bit challenging in the first few months. So you have to be honest. It will be a bit challenging in the first few months, but you have to make some very big lifestyle modifications. Every time now you have sexual intercourse, you have to use a condom, okay, or the barrier method. You have to use barrier method, and it is really important. It's for you to let the person who you are engaging with, let them know that you do have this diagnosis, okay? But in the meantime, let me set you up with the HIV clinic, okay? We'll give you some medications. He may even say, "Can you please just recheck? I'm really not, I think that they may have made a mistake. Doctor, please recheck for me." Fine. Honestly, we cannot refuse. This is a life-changing diagnosis. If they want us to recheck it, we can say, "All right, let me just check with my team leader, and let's see if he'll agree for us to do another check." But by all means, if it will make you comfortable, we can recheck it. So you're going to go home now, or where are you going to go from this visit? I think I'm going to go back to work. It might be best for you to take the day off, okay? And I would like you to be in the company of somebody who is supportive. Like, do you have some close friends you can spend the rest of the afternoon with, right? And if you are having a challenge with this condition, please come back to us. Okay, that's how you deal with it. Now, In the NHS hospital, you will get very many people who will complain to you. They will complain about very crazy things, the minor things and major things. And then there are also other people you would have to deal with, colleagues who just love doing mistakes. Okay, so you have to be compassionate because everybody is given an allowance, right? Because even you and I have made mistakes, so you have to give an allowance to those who make mistakes. Someone who has made a mistake, don't be too fast to tell them they have made the mistake. Okay, you never just attack somebody. All right. So if you have a student who is always sleeping in rounds, or a student who's always coming in late for rounds, or a doctor who's not doing their work, forgetting to put in Foley catheters, forgetting to write their notes in the chart, okay, or a doctor who's just lazy. You never want to go to them and they're at the desk and then you say, hey, Dr. John, do you know why I want to speak to you today? Do you have any idea what I want to tell you? Do you have any expectations from this conversation? What is all that rubbish? People really surprise me. You can't say that. You never ask somebody, do you have an idea why I want to talk to you? Or do you have an idea why I've called you to my office? This is not high school and that's not the principal's office, okay? So those are the big don'ts that I see a lot of my colleagues doing, and I'm like, ugh. Well, please stop doing that. Go in with a smile. How are you doing today, James? Okay. Even with a parent who's doing the wrong thing, maybe a Munchausen's, woman who is injecting some substance into the child's IV line. Okay. You want to go and ask her, how are you doing today? How is your child doing? Or if it's your colleague, how is the job going? Any challenges? You have to gather some data about the child if you're going to reprimand the mother. Okay. And then you break the news. The reason why I want to speak to you is because of this. So approaching somebody who has who's made a mistake, I have a little bit of a template. Now, if you're working with a doctor who is blatantly violating patient privacy, so which ways can you violate patient's privacy? In the elevator, the doctor is talking about a patient. So in the elevator, Dr. James is talking about a patient who came in and had, an overgrowth of a tumor in the middle of her back, okay, or an overgrowth of a tumor in the middle of her chest. Or another doctor violating patient privacy is maybe he left his notes on the cafeteria table, and then you found another patient reading them, and now he's in trouble. Another violation of patient privacy is the one, maybe a patient, he's posted patient information on his blog. Okay, so he has a blog where he has telemedicine and he's talking to people in the world about different conditions, and there he's made, for example, Samantha Jones, a patient of mine, had cancer and I treated her and she's doing much better now. Okay, that's how people violate patient privacy. So let's say, for example, you have to talk to one of your colleagues who has violated patient privacy. You go into the you find him at the desk. You say, hello, hey James, my name is Dr. X. I'm one of the FY2s here. Can I talk to you for a few minutes? It looks like you're busy. Acknowledge what he's doing. I can see you're looking through the BNF. What medication are you looking at? I'm looking at paracetamol. I'm trying to find out, what's going on here. Okay, do you have a few minutes to talk to me? Have you had some breakfast or have you had lunch? Can we grab a coffee as we talk? Or you can say, maybe we can grab a coffee afterwards. How is the unit? Okay. The thing is, because you're going to be telling him later on he's violated patient privacy, you don't want to be overly friendly. You want to maintain a little bit of a seriousness. Okay. The unit is fine, Dr. X, I'm just doing my stuff here, enjoying myself in psychiatry. People in psychiatry are so crazy. People in psychiatry just run around, chasing the nurses. They are so confused. So if the doctor is very nonchalant, and you have to tell him, correct him right there and then, or it will be confused that you are on the same team as he is, the doctors who make fun of patients. You have to tell him, no, this is not a crazy unit. The psychiatry is not a crazy unit. Unfortunately, patients here present with a different presentation from maybe the cardiac floor. So for example, if someone on the cardiac wing is having a heart attack, they'll present with the chest pain, someone here on psychiatry who is having an altered mental status will present with maybe shouting or yelling. Okay. And this brings me to, you know, some of the information that I saw on your blog. You know, I'm really, I like the job that you're doing in telemedicine, that, you know, you're really trying to help other doctors out there to study for their examinations and to learn about different disease presentations. But I saw that you had mentioned Samantha Jones has cancer, and you know, that she had a bit of a confusion while she was on the unit. Okay. And then if he's still joking about it, then you have to increase the level of sternness and say, you know, I would appreciate if you can just take a few minutes and just be a bit serious, because this is important. Anytime we violate patient privacy, we destroy patient trust relationship. Okay. Medicine or healthcare is on great foundations, or on the doctor keeping the patient's information private. They are vulnerable. Okay. It has taken a long time for us to reach to this level where a patient trusts us. In the past, patients and doctors never had a good relationship, and those who've gone before us have really invested in making sure that this is not the case. So if a patient happens on your website and sees their name, or, you know, any member of the public sees that you are exposing a patient's disease on, you know, for others to laugh about or to comment about, then this will pull down the whole medical ministry as a whole. So let's talk about Samantha Jones. So you have to gather your data. What was Samantha Jones admitted with? She had cancer. Okay. Did you speak to the nurses about why she was having this confusion, why she was running around with a broom, you know, chasing the nurses here, or why she was thinking that she's Donald Trump? Okay. You have to find the data. Okay. And you tell him, usually when a patient presents with altered mental status, get a history. Talk to the nurse who's taking care of the patient. Do a neurological examination. They could have thrown a clot. They could be in sepsis. Okay. And then you find out from him, if you did not do this, after I'm done talking to you, it might be best if I go and evaluate the patient to make sure that they're okay. All right. So you have it on your website. Have you posted any information about anybody else on any other website? You know, on Facebook, on Twitter, on Instagram, through text messages, on WhatsApp groups. You cannot do this, even with just the first name. It can always be linked back to you. You'd rather use in initials, but even with initials, it's the concept of discussing patients' information that is wrong. Okay, find out if they've done written information, documentation, pictures, videos, and then you say, if you've posted the information, for example, on Twitter and on Facebook, you need to go and delete all that information. If you've put up pictures, if you put up videos, you need to send emails to their customer services and tell them to delete it from their servers. Anybody who has shared this information, you have to send messages to them and tell them to delete it. But it's better to contact the company, because then they will delete all the information for good. Okay. So what are we going to do? Focus on deleting this information right now. I am going to go and evaluate the patient. Okay. Make sure that they're okay. And then you'll need to go and talk to our consultant about this. Okay. So the case doesn't just end there. You tell him, well, stop doing that, keep doing your good job. No, he has to go and talk to the team leader. Okay. Because the thing is, patients whose information privacy has been violated, the doctor can suffer heavy penalties, including suspension, and some even jail time. It's a really big grievance. Okay. So after this, we can go talk to the consultant, or just go and talk to him. And then if he says, oh, please, can you just keep it between us? I don't want to go tell the consultant. So you have to let the team leader know, just in case this information, you know, ends up in the wrong hands. You don't want to have it escalate without you knowing. And it's your duty to your patient to update the team leader on their status. Okay. So now he may advise you on what to do next. including telling the patient and the family. So you may say, please, we don't need to tell the patient, we don't need to tell the family. I think they are also very archaic. They'll not be able to understand what is going on. You say, no, it's our duty. Whether we do right or wrong to the patient, especially when we do wrong to them, we have to fess up. You have to be honest with them and tell them, okay? And then in the end, you just don't leave him like that. You tell him, however, this may escalate because you know he might be fired. However, this may escalate. Just know I'm here for you. We do make mistakes. Sometimes the mistakes are, can escalate really far to a point, of no return. But just know I'm here. I'm here to talk to you about it. If you do need anyone to talk to, if you need any support, I am here for you. So that's how you deal with people who violate patient privacy. Another one, who's late to work, okay? A medical student, a colleague, lateness to work, just this irritating little things, sleeping in rounds, like, hey, you, every time you're dozing off at the door, you're gonna fall down. And just go home, okay? So the thing is, and medical students especially, because we were all once medical students, you have to always dodging clinicals. They're not showing up for a week. They have all these lies. They're just studying for their exams. Have mercy on them, okay? But you want to at least give them some information, all right? Don't be a mother to them and lecture them, okay? So you have a student here, James, who is always late, and you have to talk to him. Go to him and say, hi, James, I'm Dr. X. I'm one of the FY2s in this department. How long have you been with us in surgery? I've been here 3-4 weeks, I'm enjoying it. All right, that's good. What year of school are you in? Another thing is with rapport, when you're talking to someone, try not to be too sticky. Oh, do you enjoy it? Or how is school life? Do you like theory? Do you like clinical? You don't have all time for all that, okay? You have to just be nice and easy. Find out how they like the unit, are they having any challenges in school right now? I'm having trouble in anatomy. Okay, wow, anatomy was one of my favorite subjects. We can discuss about, what is troubling you, and maybe, I can share some of my medical school notes that have been in the archives, my Maham's notes. You can use them, okay? So that's how, just a little bit of rapport, because you have a task. You have to tell him about his lateness. But ask him, don't ask him directly, are you late to work? Ask him about time. Open up the conversation, because that's how you'll find out more. So what time do you get here? I get here at 9 o'clock every single day. Yeah. Do you know the policy on the surgical unit about coming in on time? Did you hear about it in orientation by any chance? Surgery, usually the times are very early. You know why? Because we have to anticipate complications. So we come in early, we do our rounds. They're actually pre-rounds, which are very important for you to make. These would probably be between the hours of 6 and 7. Okay, you come in. I'm usually here around that time. If you have any questions, we can do a one-to-one session with our patients. That way, you can get ahead of the medical knowledge. Yeah, so you come in at 9 and we start at 7. That's a little bit late. Have you been having any health issues? Be nice, doctors. Have you been having any health issues? Are you having transport problems? Best still, just say, can you just give me an overview of your day from when you wake up, including all the times? I wake up at 9, I have my breakfast, I'm out of the house, or I wake up at 8, I have my breakfast, I do my laundry, and then I get on the bus. The bus is a half an hour ride. I get here by 9 o'clock. I just stop by the cafeteria, grab some Starbucks, and then come up to the unit. And then I'm on the unit for 3-4 hours, go for lunch, then go home. What time do you get home? I get home at 4. Okay. And now what time do you sleep? I sleep at around 3 in the morning. Oh, okay. Wow. So from 4 p.m. to 3 a.m. you're just studying? Yes, I am. Wow. And you're not suffering any fatigue or any burnout? That's quite impressive. Even in my days, I never used to study that much, James. Is there a reason why you're studying this hard? I have my finals. I need to pass them. Understandable. Okay. I also faced some of these challenges as a medical student, but looking back, I appreciate the people who told me where I was going wrong. You need to work hard and smart at the same time, but you don't want to overwork yourself because you will build a resentment to a profession that you'll be in for the rest of your life. So you have to enjoy these days. Okay, so let's make a plan, and that's what you want to do with him. Don't first say, I'm going to send you for these classes. You need to go sit in a time management class. Relax. You be the time management class for him. You tell him, all right. And if there's a pen and a paper somewhere, draw it out. Draw out a clock and say, from now you have from 4 p.m. when you get home, rest. Enjoy a walk, relax, put the books down, hang out with some friends, and then pick up the books after 2 hours. You'll be more refreshed. Study for a little while. And now, if your study is mixed with educational videos, study groups, a personal study time, then you'll be able to get more information in 3 different avenues. How do you usually study? I just bury myself in the books and I read. Give him options, okay? Give him options, especially study groups. They're very important. Somebody in the group may be able to help you in a way that or may be able to explain a disease in an approach that you did not notice before. Okay, so why lateness is very important for you not to develop this habit is because, first of all, you are part of a medical team. Even as a medical student, there are some things the team may not be able to pick up as fast because maybe we are not spending a lot of time with the patient. As a medical student, you're spending time with them at the bedside, doing their vital signs, practicing your little procedures on them. Okay, you may gather very important information that will help in solving their medical dilemma. Okay, so you are an important person in this team. Okay, you can pick up something that somebody has overlooked. Another thing is, anybody who is not up to date on the patient's information, that person increases the risk of error for the patient's management. For example, if we say in rounds at 6 o'clock, the patient needs not to be in bed. The patient needs to be in bed until their procedure. If you miss this vital piece of information and you come in and walk the patient, you put the patient at life's risk, okay? You put the patient's life at risk, okay? Or if we've stopped a medication and you come in and you notice that the patient is getting the medication, you'll be able to save that patient's life, okay? So these are the few things. Why do we need to start now? Because as you develop into a doctor, you will have more responsibility. You will need to manage more patients at the same time, and not only patients, but the rest of the team. Develop good skills now. Okay, so now you tell him, I've talked to you a lot about this, James, and I'm really sorry. I didn't mean to come off, as condescending or judgmental. I just want to help you because I see a good potential in you. We really appreciate our medical students. What is one thing you're going to change from today? You have to make sure he has a plan. Okay, doctor, I'm going to start sleeping at 10 o'clock. Okay, good. Because even you'll notice if you sleep at 10 and wake up a little bit earlier, it's more quiet in the morning, you're more refreshed, your brain has rested. You'll notice you can retain more information, okay? Or if he says the bus is late, ask him, will you now start taking the train? Okay. If he's not snoozing, or if he's snoozing too much in the morning, will he set an alarm? Okay. Or if he's living very far from the hospital, you can say, maybe you can carpool. Or you can talk to your school and see if they can give you a clinical setting that's closer to your home. All right. So make sure there's some form of re-understanding that he says at the end. What are you going to do now? If he tells you, are you going to tell on me to the consultant? No, at this point, there's no need. And think about it, guys. If we are so busy on the floor, can you imagine now me going to the consultant and saying, hello, Dr. Smith, we have a medical student here who is always late. He'll be like, what? I don't even know half of the names of the junior doctors, let alone the medical students. What type of rubbish is this, Dr. X? Go back and do your work. Aren't you scrubbing in today? So we can't be telltales. Oh, I'm going to tell on you. I'm going to tell on you if you don't come in late. You tell him, so tomorrow, come in early. Come in early. If you come in early tomorrow, I'll go over some anatomy with you. And you know what? I'll share with you some of my super notes that made me get an A in anatomy. So you've given him a motivation to come in early for the next day. And you say, come in, sit next to me during rounds. I'll show you how to take some good notes about patient care. Or come in early, and I can go over some of the physiology things that you need reinforcement in. Okay, moving along. Delayed patient care. So these are those colleagues who they never finish their work. They're always like the heads are always in the clouds. So either they're delaying an antibiotic, or they're delaying an admission, or they've forgotten a patient in a cubicle, then they went for lunch, and then you're walking around and there's somebody saying, hello, excuse me, I've been waiting here for 2 hours. Oh, which doctor was seeing you? Dr. James again. Okay, or somebody who delayed the discharge of a patient. That's also a very big thing. And if you look up on the NHS websites or in the UK, there's such a big backlog in emergency rooms because the floors are not, or the wards are not discharging patients that need to go. If they need to go, they need to go. Get them out. So now let's take this scenario that may have happened a couple of weeks ago with Dr. James. Okay, there's a patient, Samantha Jones, who was admitted with pneumonia. She's going home today. Okay, all her lab work is ready. Prescriptions are ready. Dr. James was supposed to discharge her at 8 o'clock. It is now noon. The emergency room is complaining that the patient has not been discharged. Of course, because those are the ones, if at all, one of the major calls that you get on the floor is from the emergency room. Intake is calling saying, where is the bed? This patient is supposed to have gone home at 8 o'clock. What's going on? Because we need to clean the room also, all right? Or the ward manager is complaining, or everybody's complaining about Dr. James. Go speak to him. So you find Dr. James with his head, his heels up, drinking his Starbucks, and you say, hello, Dr. James, my name is Dr. X. How are you doing today? I'm doing fine. It's busy on the floor, right? Yes, it is. How many patients did you start with? I have 25 patients. Okay, that's quite a lot for an FY1. Okay, is this the regular number that you've been getting over the days? Honestly, and in fact, and he says, I'm the only doctor on the unit today. Dr. Sally didn't show up. Dr. Patel didn't show up. So I've taken over all the patients. So you have to be compassionate with him. Okay, he has 25 people he needs to take care of, and he's not even finishing some of the tasks. So ask him, what do you have left? I have a cannula in room 3. I have a Foley in room 4. I have another discharge that I've not even done yet. But if he's forgotten about the discharge, you can always ask anything else that is pending on your list. I don't know. I think I'm caught up with everything. Then you tell him, I've heard from the ward manager that Samantha Jones is still waiting for her discharge. Oh man, Dr. X, I'm so sorry, I forgot. Understandable. We do forget things, but discharges, James, admissions and discharges, we cannot forget. It's very, very crucial. These are types of patients that you always have at the top of your list. Okay. Of course, you have everybody else, but always highlight these patients: discharges, admissions, IV antibiotics, and anybody who is going into surgery. Okay. Can I know what was going on around the time that you are supposed to discharge the patient at 8? That is your data collection. Well, I had a CPR, class, or somebody collapsed in the hall, and I had to perform CPR, or I went for my lunch. Depending on what they say, that's why it's so important to ask what was happening around that time. Depending on what they say, you have to give a solution for that. Okay, if you went for lunch, come on, James, you have to do your work before you do lunch. Or eat lunch earlier on, and then, get on with your work. Or if you had the CPR class, You can always take the CPR class later. But if it was an emergency, you have to show a bit more compassion. A patient collapsed in the middle of the floor, and I was doing chest compressions. What was the outcome? The patient died. Oh, wow. Then you're having a tough day, James. Now I can see why you're so backed up. It's midday. You had a discharge at 8. You have Foley catheters all over the place. We can even ask for some help. And sometimes, because we work as a team, it's important to let somebody know. Let the nurses know, because one of the nurses could have just gone and talked to one of the other house managers, or would have talked to one of the registrars, and then we can see what we can do. All right. But I'm sorry that you had a bad outcome with the CPR. I hope that next time you'll be able to have a good outcome. We do lose our patients sometimes. Okay. So now, then the next thing is, you have to now deal with Samantha Jones. So Samantha Jones has had pneumonia, and now the pneumonia is better. She's going home. You need to go and do the discharge. Dr. James may tell you, can you please do the discharge for me? And that's what becomes a bit tricky with discharges. You tell him, I would like to do the discharge, but a patient who is on your team deserves to have follow-through care. So the doctors who have been with her throughout her admission need to be the ones to send her home. Why? Because they can pick up anything that may have been amiss in her care. They will be able to pick up if she's having any changes in her health. So because I've not seen the patient before, if I go listen to her lung sounds and maybe they sound a little bit worse from when she had on presentation, I'll not be able to pick up this really critical finding, including her medications. I do not have any background on what she has been taking, what has been discontinued. But you, because you've been following her, you'll be able to pick up these critical factors. Okay. So tell me what you have to do. I'll go do the Foley catheter. I'll go put the IV cannula. You need to go do the discharge. When? Now is the best time. The thing is, if the patient is upset and she wants to complain about you not doing the discharge on time, how do you deal with an angry patient? Let her vent. Okay, so go in, apologize. You don't need to tell her the full details of the CPR and make all these excuses. Listen to her. If she wants to complain, tell her she can speak to the ward manager. But when you sit down with her, take your time and do the discharge in the right way. Do a full physical examination, her exit vitals, make sure all the scans are back, check in with the consultant about the prescriptions, okay? And then now find out who is picking her up. If she's having problems remembering the medications and the side effects of the meds, print out some leaflets for her to go home with, recheck her understanding about the symptoms. That's how you discharge a patient, okay? I'll take care of everything else for you. In the next, in the future, if you are getting, backed up, call out for us, we're here. Even the nurses can help, try and mobilize other doctors to come and help you out, okay? We work as a team, Dr. James. Yeah, good. Okay, delayed patient procedure. Dr. James is back again. He's not put an IV cannula and the patient has missed their dose of antibiotics, or they've missed their dose of heparin, or they've missed their dose of pain medication. But the IV cannula was not inserted. So now here, what's the main theme? What do you do when a colleague fails in their duties? Problems, are they having problems in time management? What are some of the possible hazards when medications are missed? How do you help a colleague who may be struggling and doesn't want to ask for help? All these questions must be running through your mind when you're talking to someone who is delaying patient procedures. So James has now forgotten to put in the cannula. Hey, James, it's me again. Didn't you forget yesterday to discharge the patient? Now you're on my list of people who've not done their cannulas. Okay, give me a little bit of a recap of course, you're not going to start like that. I'm just making fun of the whole situation. But you start the case the same way. So, rapport. How are you? How is the unit? Any challenges? Who is the patient? And it's so important because the patient, let's say, is Catherine Smith. She's been admitted here with sepsis. and now an IV cannula has not been put and they've missed antibiotics. This is a big deal. So now if you gather the data, you'll be able to manage the case, all right? So you have to find out what was happening around the time when you were supposed to do the cannulation. Do you have trouble putting in cannulas? Because some doctors are a little bit not that apt with their skills. Maybe he needs some help, okay? So it's good to ask. If he's having a hard time, cannulations, you can say, all right, maybe we can go to the skills lab afterwards, or you can sign up for the IV course that's given every month, just to increase your skills. Or you can go down to the emergency room. One of my friends, Dr. Patel, is there, and he's really good with cannulations. He'll teach you, and you'll get the experience. But find out why before you blame. Okay, so now the cannula has been missed. You found out the history of the patient. Maybe she has a DVT and she's getting heparin. So now you can be able to tell him, IV cannulas, even though they seem like they are a very small thing, are very important in the hospital, in the surgical unit. So the patient came in with, sepsis, and now we've missed an antibiotic. So the thing is, the cannula has to be put in immediately. Even nurses can put in cannulas. We don't want to delay medications. If a patient misses a medication, James, unfortunately, we also have to write an incident report. Okay, and the incident report is not to make you feel bad or to keep a record of your wrongs. It's just to, it's used as a teaching tool, especially to all the new doctors who are coming in to see potential loopholes where mistakes can happen and why they can happen and how to prevent them in the future. Incident reports make us better doctors, and also they protect the patient. It keeps us on our toes to make sure that we are doing what is right for them. Okay. Now, delayed medications can have bad side effects or serious side effects. The patient was a DVT. If we are delaying the IV cannula, we are delaying the heparin, the clot can enlarge, the clot can they can have an embolus to the heart, cause an MI, embolus to the brain, can cause a stroke. IV medications, antibiotics missed can increase antibiotic resistance. Seizure medications missed can lead to, so you have to draw a good picture for him why it's not good to miss IV antibiotics. And you tell him, on your list, do you have a patient's list? Yes, I do, doctor. Okay. Do you organize your list according to room number hierarchy? I do organize it according to room number. Okay, that's fine. And you can tell him how I organize my list is I split my paper in two. I have my list according to room number, and I also have a list according to hierarchy. So room 1 maybe be somebody who's having a hip replacement. Room 2, maybe a cardiac procedure. Room 3, maybe they had a pilonidal cyst that needs to be removed for etc, etc. On my hierarchy, my cardiac patient is first. Then the second one may be the hip, and then the third one is the pilonidal. So that anyone who has antibiotics for sepsis needs to be all the way at the top. In fact, highlighted with yellow or even red. And during your rounds or during your hospital shift, these patients, you have to keep checking on them just to make sure they are okay. All right. For this incident, you have to let the consultant know. And they'll be like, why? Why do I need to let the consultant know? The worst thing I hear people say when it comes to reporting to a consultant is they say, you need to go tell the consultant so that you can tell him before anybody else gets to him first. Or it's better if he can hear it from your mouth before he hears it from other people. That is so much rubbish, honestly. Why do we report cases to the consultant? So that we can be number one there, telling them, oh, I reported myself. No, we tell the consultant because he's a team leader. He's the one who makes the overall decisions about the team. He needs the full picture about the patient's care, the good things and the bad things that have happened. If the antibiotic has been missed and he's looking at the lab work and the white blood cell count is still high, he will think that the antibiotic is not effective, or he'll think that the dose needs to be increased. So he may change these And who's going to suffer? The patient. But now if you tell him, I miss the antibiotics, that's why the white blood count is still high, he'll understand, okay, don't repeat that again. And then he'll understand better how to manage the patient. But if you hide mistakes from the team, it's not you who will suffer. It's not anybody else who will suffer. It's the vulnerable patient who suffers. And this is not right, okay? And so I said here, what incident reports helps us monitor potential problems and the root causes of these problems. You can learn from this mistake and it will help us in our practice. Another thing is why antibiotics or IV cannulas need to be put on time is for drug-drug interactions. A patient who misses the antibiotics scheduled at 4 needs now to be pushed to a different time. There could be another medication given at 6, and that can interact with the antibiotics. So it's such a big deal. IV cannulas are such a big deal. You have to talk about those possible hazards when the medications are missed also. And the consultant needs to be told. So there's none of that fishy. Please don't tell him, please. No, he has to know. He has to know. Okay, good. Now let's get into some internal medicine, and then we'll take a quick break, and then we'll come back and continue. After we finish pediatric medicine, we can do a 15-minute break. Okay. Pediatric medicine is 100% easy. Please do not be intimidated by pediatric medicine in the NHS. One of the big things is vaccinations. That's one of the things, if you're working in the pediatric clinic, people will be coming in for vaccinations. They want to know about the flu vaccine, MMR vaccine. Another one will come in and say, my child is 13 months. What do they need for their vaccination? Or my child is 8 weeks old. They're coming in for their first set of vaccinations, the 6-in-1. Okay, so it's important to know a little bit about vaccinations in the clinics. So for example, the nurse tells you, well, Samantha Jones is here and she has a 3-year-old child who is due for the flu vaccine, or they are here now and they are due for the flu vaccine today, but the mother wants to talk to the doctor. So you go in, hello, my name is Dr. X. Can I confirm that you're Samantha Jones? And it's really good when you have a patient to know their name when you're walking in. Never just go, what's your name? What's your name and what is your age? Ask them, can I confirm you're Samantha Jones? Yes, please. And we don't ask patients' parents their age. So you wouldn't go, how old are you? No. A mother bringing in a child, let them be. Let them hide their age from you. Ask about the child. How old is your child? He's 3, and his name is Sammy. Okay, that's a nice name. Why did I say that? Because I have a sibling called Sammy. Okay, so don't fake also. Don't fake your IPS. Okay, don't fake your interpersonal skills. How old is the child? He's 3 years old. All right, so I hear that you have some concerns from the nurse. Yes, sit back and listen to the concerns. Never compete with the mother who has questions for you. You want to hear what's going on. Doctor, my child is due for the flu vaccine today, and I'm really very hesitant about this. Oh, can I know why? Well, me and my husband had the flu 2 weeks ago. I had to call out of work for 3 days. He was out of work for 4 days. We were really sick. I'm sorry to hear about this, Samantha. How are you doing now? Did she just tell you all that for you to just grin and not acknowledge? You have to say, how are you doing now? Okay, how bad was the flu? And did you have a fever, muscle aches? Because you want to see, is it a common cold with just a runny nose, sore throat? Or was it the flu? Okay, how about your husband? How is he doing? He's doing much better now. He just has a little bit of a remnant of coughing. Okay, did he also have muscle aches and a high temperature? Okay, did you visit the emergency room because of this? No. What remedies did you use? We just drank our hot soups and drank our orange juice and were okay. So your child was around you when you had the flu. Have you noticed any symptoms in your child now? And sometimes the patients may ask, symptoms like what? So you can say, well, maybe the symptoms that you had, fever, the coughing, any shortness of breath where they're having trouble breathing or wheezing while they breathe, runny nose, and he's 3 years old. So symptoms of infection in a 3-year-old may present in different ways. So he's refusing to eat, his appetite is really low, he's tugging at his ear, he's very irritable, or when he cries, he's just very unconsolable. His routine is just off. Okay, so he's not sleeping well, he's waking up in the middle of the night. These are just a few things that you can notice in a child if something is really not going on that well. Okay, so I'm glad that you and your husband are feeling much better. Now your child is due for the flu vaccine, according to my note, or according to the nurse. So what is the main concern about the flu vaccine? Well, I want to find out if this flu vaccine causes the flu. Okay, that's a good question, Samantha, because that's a big misconception in medicine today, that the flu vaccine causes the flu. On the contrary, it doesn't. Usually, sometimes people get the flu vaccine and maybe they already had the flu virus just brooding in them, what we call like a prodromal phase, where they've already been attacked by the flu, and now they get the flu vaccine, and then they get the symptoms and they think that the flu vaccine has caused it. All right. There are a few symptoms that you can see after a flu vaccine is given. Sometimes you can get a bit of a runny nose, slight fever, maybe sore throat, muscle aches for about 1 to 2 days, but this is not the flu. The flu, as I explained before, can even be very life-threatening. Okay, you have muscles are very tense, very high fever, a lot of irritability. Okay. And even when we give the flu jab, some of the things we tell the parents to watch for is a bit of a slight runny nose, a slight fever, but nothing more than that. It should not cause a full-blown, the flu symptoms. Okay. So then you have to wait for the patient to ask you more questions. If they don't ask you any questions, you can say, can I ask you some questions? So your child is 3 years old. How are they doing? What are some of the interesting things that they do? I always try and make a nice environment for your consultation. Make a nice aroma. Okay, nice environment. Don't be all medicine. Find out, because there are so many things to ask, but ask them about their child. Are they in kindergarten? They are 3 years old. Three years old is when they get the first tricycle. Are you considering this? Yes, we've bought him a tricycle. Does he have a helmet? That's good. That's important. He has to have a helmet when he's riding. Okay. Anything else you've noticed in his development? Is he appropriately eating well? Any bowel problems, bladder problems at all? Have you noticed any rashes on his body? No, he seems to be okay. Did he have the other vaccinations in the past? Because you can also make this about a social visit. You want to bring it back also to the case. Has he had any vaccinations in the past? Has he had any reactions from those vaccinations at all? No? Okay. Who's at home with him? The mother, the father, any brothers, sisters? Is the environment safe for him? The 3-year-old, you have to really what we call a safety proofing the home, where even electrical outlets have to be plugged in with specific devices so that the child is not putting any objects into the outlets. Okay, the toilet seat has to have a latch on it. You have to make sure you close it down. If you have a staircase and he's not really that safe on the staircase, or it's really high, you have to have gates. You have to child-proof the home until the child is able to understand these type of things. Just a few things for them, okay? All right, so back to the flu vaccine. Can I give you more information, Samantha? Yes, doctor. So the thing is, now, a long time ago, we used to give it as an injection, but now for a child of 3 years old, it's given as nasal drops. Okay, and it has been shown, a lot of research has been put into it. It's better absorbed, better protection. Okay, does your child have any medical conditions like asthma, any congestion right now, any runny nose? Okay, no. Then it, if it's okay with you, then this is the route that we would use. Okay. All right. And then she may ask you, how does a flu vaccine work? And this is where most people have a hard time. Don't get too pathophysiological in your explanation. Just say, we have immunity in the body. The flu vaccine raises the immunity and just prevents a shield against the flu. Or how did I put it here? It causes antibodies to develop against the flu. But I have to tell you though, there are very many strains of flus. For example, A, B, C, D, E, F, G. We may give him the flu vaccine for strain G, which is the most popular strain for this season. So maybe last season it was strain A that was really causing trouble. Now it's strain G. He could still get another form of flu, even though we give him this protection against the most common flu. So it's important to tell the mother that, so that she doesn't say, my child got the flu vaccine and then now they have the flu. I thought it was supposed to prevent them. Okay. She may ask you that common question, is the flu like the common cold? It's not, because both of them are caused by two different viruses, and the flu is very severe with life-threatening complications up to pneumonia. Okay. The common cold is usually, 1 to 3 days, sore throat, itchy, discomfort in the ears. Right? Then you can ask a question, does your child have any allergies? Well, my child has an egg allergy, doctor. When did you notice the egg allergy? What happened? Did they have any wheezing, drooling, closure of the throat? Were they admitted? We have to get details about this. Okay. And why I'm going a little bit slow about these cases is because they're poorly taken care of. There's a lot of patient dissatisfaction when it comes to simple cases in the NHS. All right. Find out what happens when they eat the eggs. For severe egg allergies, we may not give it because the flu vaccine is developed around eggs. All right. So there you go. We have one very important question to ask this woman is, will you allow us to give the flu shot? Okay. If so, this is a really good, you congratulate her. Thank you. This is a good choice to make. We can give the flu shot today, or you can come in in 2 weeks when they are scheduled for it. Okay. And then, or if she says no, don't say, I feel so bad, I've not convinced you, or what can I do to convince you? No, give people their space. Tell them, okay, let me give you a bit of time. I'll have the consultant come in and speak with you, or one of my senior registrars to come and talk to you about this. But if she says she's going to do it, give her a little bit more information. After the flu vaccine, he may develop a bit of a fever. Okay, it shouldn't be real, it shouldn't go high. And please watch for any fits, okay, or any, the child is looking very lethargic or not themselves. Please come back to the clinic. Okay, good. Let's talk about the next one, another vaccination, MMR. A 13-month-old is scheduled for MMR vaccine next week. You have to talk to the mother. So you go in, and the biggest thing with MMR right now in the NHS is this misconception. It's actually not even in the NHS also, but even American medicine, maybe even medicine back in my home country, MMR has such a big stigma. And there's even a whole organization called Mothers Against Vaccination. I don't know how many million followers are there on that in that organization. And it's because of a big misconception. So this is an opportunity for you to educate this woman. And so if she's part of that organization, she can go and also educate them. So make sure you talk to her very well. Yeah. Hello, Samantha Jones. My name is Dr. X. I'm one of the juniors in this pediatric department. I can see you have some concerns. Yes, doctor. My child is scheduled for this MMR vaccine, and I'm concerned because I don't want them to get autism. Okay, that's a valid concern. Can we talk a little bit more about this? Thank you very much for coming to the hospital today. So where did you get this information from, if I may ask? You have to be polite, okay? I read online about, the autism is caused by MMR. There's so many videos on YouTube showing children who are very okay before they got the vaccination, and then now they are really having a big challenge with autism. Okay, so I see you've gotten, you have done a bit of research about this. You know, yes, the internet is valuable for a lot of information in more business technology, but in healthcare, it's really important not to get your information from the internet. There is a lot of bias. There's a lot of input from medical and non-medical fields. So it's not very, very sound management. The best person you can talk to is a doctor. So thank you so much for coming in today. Now, yes, autism is a challenging condition. Yeah. And now I can see why you are concerned. Don't say, I understand. Don't say, don't worry. Say, I can see your concerns. And how do you see concerns? After she said them to you. You can't just see nothing. Okay. Now, if I can give you some information about why there is the misconception between MMR and autism, is there was a lot of misguided literature that was given by one of the physicians who said that autism is caused by MMR, but he was also misguided because after a lot of research by different ministries across the world, it has been seen that MMR and autism have no link. Why people may think there is a link with MMR and autism is because autism symptoms usually start appearing around the age of 13 months or around the time when the MMR vaccination is administered. So that's where people made this unfortunate link. But now a lot of research has been put into looking into the MMR vaccine, which is 3 types. Okay. So now, do I have to keep asking, do you know what MMR vaccine is? Can I tell you what MMR vaccine is? No. Make it a nice conversation. It's a 3-in-1. It's for measles, mumps, and rubella. Okay. Don't say rubiola. Some people have made a mistake and said rubiola. Measles, mumps, and rubella. Okay. All these infections are caused by viruses, and they can cause life-threatening complications in the child. Now, some doctors want to say measles has these complications, 1, 2, 3, 4, 5, 6. Mumps has these complications, 1, 2, 3, 4, 5, 6. Rubella has these types of complications. It is this type of class of virus. The patient has no tolerance to listen to boring medical language like the way medical language that interests us. Make it into a nice little package and say, MMR, measles, mumps, rubella. It causes life-threatening complications. For example, meningitis, deafness, and it can even cause some eye and heart complications or defects in newborns. This is why it is so important for us to give it. And the more that we have vaccinated our population, we have seen incidences of MMR declining in the population. Okay, so now she may still not be convinced. If this woman says, so then you can always gather some data. Ask her, have you had any diagnosis or anyone in your family who has had the diagnosis of autism? Do you have any friends who have children who have this diagnosis? Yes, doctor. Okay, and some of the symptoms are important, yes, to watch for with a child around the age of your child, 13 months. Can I ask you a few more questions? How is your child? Are they running around? They're 13 months, yes? What are some of the interesting things they do? Again, just like I said in the other case, are they walking? Are they talking? Do they have any delays in their development? Are they isolated? Okay, are they fixed on any particular object? Are they very particular about a routine or people who are very familiar to them? Okay, do they have very large outbursts and tantrums, especially when they don't have their way? Okay, any abnormal posturing of the body, any lip smacking, head bobbing or head banging, or any repetitive movements with their limbs. So you have to do a little bit of a history taking with this child. Did they get their other vaccinations in the past also? And then you can even ask, do you have their health immunization record? Yes, doctor, I do. Did you bring it? They may show you the immunization record. Open the immunization record or the red book and see, okay, I can see she had her 8-weeker. She's been having her flu shots. This is good. You've been keeping up with these vaccinations. So a nice way to kind of uplift the spirits of the mom. But you have to rule out any symptoms of any infections. Also, you want to ask about any infections. How is their diet? How are they eating? Are they toilet training? Have they begun now? Well, 13 months. Well, you can always ask how many nappy changes to assess dehydration or nutrition status. What types of food are they eating? Nice, good questions. Then now you ask her, are you going to consider taking the MMR vaccine? Yuli, I don't know because, I've not even heard of, my cousin had mumps, but I've never heard of measles in this country. Measles is very rare. Okay, and it may be this way because you may think that measles, mumps, and rubella are very rare, but they are incidences where breakouts happen. And it is for these incidences that I want you to be protected. Some people say things like, no, people come from abroad all the time and they're not vaccinated in their country. Your child may travel to another country and you want them to be vaccinated. Well, those are kind of weak reasons. I usually say, why do you want to vaccinate? Is to protect your child against a sudden outbreak. It has not been eradicated. Measles, mumps, and rubella has not been eradicated fully. If there is an outbreak, those who have been protected or those whose immunity status has been protected against these diseases, they will be able to survive. It is going to be a very narrow chance if an outbreak occurs and you don't have even a chance to get to a hospital to get the vaccine. So you have to kind of not scare her, but give her a little bit of a something on my leg. Give her a little bit of an insight, okay? And you can even add and say, well, your child is around crowds. In fact, they are 13 months old. There could be children. They could be around other children who are not vaccinated. Okay, you could go somewhere to a supermarket. The viruses are in the air. The viruses are on things that we see and we touch. Okay, so it's important for you to vaccinate. Then if she says, okay, I'm going to consider it, you have to take it one step further just to give her information. So it's actually a 2-series vaccination. Okay, it's given into the muscle, into the thigh or upper arm. Okay, and it's given at an interval either between the 9 and 15 months of age, and then the second dose between the 15 months and 6 years. But if they get it the first time, the second time they get it, there has to be a 4-month interval between both shots. All right. And sometimes, when we give the shot, of course, there might be localized pain, a bit of redness, a bit of a fever. And once you agree to take the vaccination, then I can talk to you about a couple of things that you may need to observe in your child. Okay. All right, let's do this. Let's go on a little break. And then we'll come back and we'll continue on vaccinations. And then okay, we are back. And let's continue with our common presentation of diseases in the NHS. Okay, so don't forget, if they say, yes, doctor, I want to get the MMR vaccine, you say it's given in 2 doses. The first dose is between 9 and 15 months. Then the second dose is between 15 months and 6 years. But there has to be a 4-month interval. And it's really important for you to be reviewing the NHS website just to see if there are any updates. CKS, NICE, N-I-C-E, CKS website also has very good guidelines. And I also use this book. I don't know if I showed it to you last time. The Foundation Program, Oxford Handbook. quite a good book for you to start if you're starting your internships here in this country. Yeah, really nice. Okay, now let's talk a little bit more about this child abuse injuries. So we've seen so many abuse cases in the hospital, you know, ranging from very sad cases where a child is coming in with burns on the arm, burns on the back, especially burns on the back. You really know that this child maybe is not being taken care of that well. Fractures, which you're wondering, how did maybe a 3-month-old have a dislocated hip, like totally ripped off the hip joint, or even a broken femur, twisted femur. This is another one where the spiral injury is also very common. So you have to know what a spiral injury looks like. So let's do this example. So you're working in the local NHS emergency room, and Samantha Jones has come in with her child, who is 4 months old. Okay, the child has a swollen arm, the child is crying, inconsolable, there are multiple bruises on the body, and so you do an examination on the child, you do an x-ray, and you find a spiral fracture. Okay, spiral fracture in 2 joints. So spiral fracture in the arm, spiral fracture in the hip. Poor kid, poor kid. You have to hold it together with these patients. You can't go in because you already know that maybe there may be maltreatment or abuse. You can't go in even with a face that is just showing anger. You have to calm down and listen to the whole story. She may be the abuser, you don't know. She could be living with somebody who's an abuser. So you have to ask the questions very carefully. And so you'll be engaged on all these things and how to prevent future events. Hello, Samantha. My name is Dr. X. I can see that you've come in with your child. From my note, his name is Jimmy, and he is 4 months old. What happened today? Well, doctor, I went to work, and when I came back from work, I found my little boy crying. Okay, who was with him at home? My husband. Okay. What did your husband say happened? Excuse me. My husband said that, you know, he was sitting on the couch and then he fell from the couch. Okay, so his age, just to clarify, is 4 months. Okay, has this happened in the past? No. Does he move around when you put him in a fixed position? No, not at all. Does he roll? No. What are you trying to do by asking these questions? You're trying to provide light or insight, like, wake up, Samantha. Your child is 4 months old, doesn't crawl, doesn't walk, can't even sit up straight, doesn't move, and now your husband has told you that he rolled off the couch and fell on the floor. But keep going with the story. Okay, Samantha, I'm really sorry about this. How high was the couch? It was this high from here to the ground. And do you have a carpet in your house, or is the floor like a hard floor? It's a carpeted floor. Any hard objects around, like a table or anything around, you know? No, doctor. So I guess he just rolled and he landed on the side of his arm, and he injured his arm. Yes. Have you noticed any injuries on your child when you're changing him? I have noticed a couple of bruising here and there, but my husband tells me that he's very playful. Yeah, okay. Your child is just taken care of by your husband? Yes. Is there anybody else taking care of the child in the home? Not at all. No babysitters, no visitors, and you don't take him to a daycare center? No. Okay. All right. Yes, you know, the bruises were quite concerning to us. And we also did a couple of scans and x-rays to his joints. And I did notice from the x-ray that he does have a fracture in his left leg and in his right arm. 1, 2, 3. So why are you counting? Because you're giving them time, yeah? Okay. So don't blame. In fact, I skipped saying spiral fracture. I said just fractures. Okay. In his left arm and in the right arm and in the left foot. You know, how is your child's diet? Because sometimes fractures can be caused if the child's bones are very weak. What does he eat? He just breastfeeds. Okay. And when you're home, do you maybe leave some milk for him in a bottle? Yes, I do. Any supplements with Some formulas, no, because even sometimes a low calcium in the diet can cause a child's bones to be a bit fragile, and even low levels of vitamin D. Okay, do you have any bone problems in the family? Bone fragility problems, any seizure disorders? And now why I'm talking to her like this and giving her explanations is because it's always so nice when a doctor can, when we say something and then we open our minds to them to understand why did they ask this question. Okay, seizures, bone fragility problem, poor diet, all can cause spontaneous fractures. Okay, so I'm just trying to find out what could have caused this. And you said there are no children in the home. Yes, doctor, just in case there was somebody who was being a little rough with the child, you know, sometimes siblings can have this type of attitude. Okay, so is it just you who goes to work, or do you alternate? You come back home and then your husband goes to work? My husband does not go to work. He lost his job. Oh, I'm really sorry about this. How long has he not had a job for? So now the thing is, what am I doing? A focused history. People love to say history has to be nice and broad, asking about alcohol and smoking and travel and all this. Do you exercise? Do you eat fruits and vegetables? All of that has its place. For this type of a case, I am focused on how this injury happened. I've done my differentials, okay, with my calcium and my seizures and bone problems, including anything in the family history, including playful mates, or and then now I'm zooming in into stress, okay. So your husband doesn't work. For how long? For the last 6 months. I'm really sorry about this. So he lost his job, yes. How is he coping with this? Well, he does have his temper tantrums, or he does have his troubles with the child. I'm sorry, troubles with making ends meet. Okay, I'm really sorry about this. There are some services that are for families, especially families who have newborns in the home. There are some job searching services that I can help you look for. Maybe you can relay this information to him when he goes home. Did he come with you for the visit? No, he's at home. All right. How about you? Any stress at work? No, doctor. What do you do for work? I work in the library. Okay, because you have to assess her and also assess the other caregiver. Some people like to ask a very mean question. Is the father the biological father of the child? Wow, really? I find that highly offensive, because you're showing that stepfathers have a higher propensity to injuring their children. That question does not have a place, and I'd rather you leave it alone, because this woman sitting in front of you with her crocodile tears could be the one who injured the child, and maybe there's not even a man in the picture. It's all lies. I'm telling you, some of the things I've seen are quite scary. So if you've had that question being asked about, is he the biological father, you might as well just leave it. You may ask, what's the environment like in the home? What is there? Is there tension? Are you able to make your ends meet? Okay. Any history of any violence or any sort, or any miscommunication and misunderstanding, quarrels? I want to find this out. Are there any elderly people in the home also? Because if this child has been abused and there's an elderly person in the home also, she also has to be investigated to see if she is an abuser or she's an abusee. Okay. And then you can just drop the question. Is the child safe in the home? Yes, absolutely safe, absolutely safe. Thank you, Samantha, for answering these questions, because I mentioned before, the child does have a fracture, and what we usually do when we find a child with a fracture, especially of this nature, and specifically his fracture was a spiral fracture, it means that the bone was acted upon in two separate or two opposing directions. Usually it is when force has been applied. Now, my main aim for your child is to, first of all, make sure that this fracture is assessed by one of the orthopedic doctors, okay, Of course, we've given him some pain medication. We'll try and also do some more interventions to these injured areas to prevent further nerve damage, blood vessel damage, muscle damage, and so that he doesn't have any complications or disability in the future. Okay, and we want to make sure it heals correctly. The thing is, we will have to admit him so that we can do this full investigation. I'll let the consultant know. He'll want to take a look at the child, right? Now the thing is, if this case comes in a different way where you have no x-ray, and then the doctor, you say, I'd like to have an x-ray of the child, and after a couple of minutes, the radiologist gives you a report and says, this is how the x-ray looks like. You want to know what a spiral fracture looks like just right off the bat. It does have this S kind of shape like this, of course, like the screwdriver. So the torsion on each side causes a shearing force in the middle, and then causes that like screwdriver fashion. Quite distinct. And honestly, this poor kid has experienced some suffering. Okay, but you don't want to make the mom alarm. You want to now take it very, very, very wisely. Okay, don't say, I think somebody's abusing your child. No, you say someone or your child may have gotten this fracture from a twisting injury. Okay. As part of our team, or as part of the management, we are going to have a social worker really evaluate the child, and also may ask you some questions. Their concern is the safety of the child now, and even when the child goes back home. The mother may say, no, please, I don't want my child to stay here. We want to go back home. And it has happened before, where even security has to be called into the hospital to prevent the mother from going home. She cannot go home, but you have to stall her. You don't want to get into a fight. You just want to say, okay, let's do this. I'll have the consultant come and talk to you. And then I'm going to make sure that the child gets the appropriate management, the treatment, the pain medication, all right? And then we can take it from there. But at least you've mentioned social services has to be involved, okay? The worst thing to do is to get into a fight with her. She punches you in the neck and grabs her baby and runs off because you've threatened her child. Mothers can be very strong. So what usually happens behind the scenes is you go quickly, you tell your consultant, you alert security, they go on, position themselves on the doors, and then the consultant comes and tells the mother, I'm sorry, you can't take your child home. So if she wants to run away, she can run off, but the child has to remain here. And then eventually an investigation is started. But don't spook the mom and don't fight with her either. So if you do see this x-ray, then you know what you're dealing with. The child has to be admitted for us to even evaluate further. Oh, good. Now, this is also something you need to know if you're working in pediatric medicine, because you may have to, as a doctor, you may have to teach pediatric BLS or even adult BLS. And even some cases, I say, as the level of expertise goes up, you may have to at some point teach a class on defibrillation. So go and look up just a video on how to put those pads and how to work with defibrillation cases. But pediatric BLS is quite daunting. The only thing is, if you are teaching, let's say the geeky medical students who are always, oh, can you teach us new stuff? Oh, please, Dr. X, can you teach us, what do you want to learn? You want to learn pediatric BLS. Okay. So if you're in the, mannequin room, then of course you're going to talk to them about an overview. Teaching anybody, nurse, fellow doctor, student, you always want to give an overview of what is going on. An opening. So you say, okay, hello, my name is Dr. X, and you're medical student A. Yes. Medical student B. Are you in the same class? Yes, we are, or I'm in third year and I'm in fifth year. You have to teach it at the level of the one who has the least knowledge. Okay, so if you have a class with different people, nurse, FY1, maybe medical student or pre-med, You teach to the level of the pre-med, okay? So you say, okay, we have pediatric BLS to learn today. Don't waste too much time gaining rapport. It is a long teaching session, and maybe you don't have too much time to teach, okay? So say, okay, once you find out the skill level of everybody, then you say, then let's get to it. Who wants to tell me what BLS stands for? BLS stands for Basic Life Support. If you have a know-it-all in the group, you let them answer 2 questions and then say, let's give somebody else a chance. Dr. Michael, let's give somebody else a chance now, okay? Relax, Dr. Michael, this is not the end of the world. Okay, so that you have to balance. If you're teaching many people, balance and give everybody a chance to speak. But don't make it a question answer session. You have to do the teaching. So you say we have basic life support. And the thing is that is very important compared to adult life support or adult BLS or adult CPR and pediatric BLS is a couple of things. If you find a child unresponsive, the chances of the reasons why they are unresponsive is because of a foreign body lodged in their throat. So first of all, you place them on a flat surface, okay? You are certain that they are unresponsive by shaking them and tapping them, okay? And tapping them on the shoulder. You don't want to do a sternal rub on a child because it's quite, you don't want to damage their fragile muscles, but you want to check the responsiveness. So let me just recap. In the beginning, you do your rapport, and then next you ask 1 or 2 questions. What is CPR? What is BLS? What is the function of it? We are trying to keep the heart and the lungs working until we find the cause of why they stopped, or until we can resuscitate them. So that's why we do it. And then now you get into the station. The child is unresponsive. Make sure they are on a flat surface. Make sure that they are away from danger. Okay, check them. Hello, baby, wake up. Okay, get help. If you're in a crowd, assign someone. Call 999. Never just say somebody call 999, because somebody can be anybody. You want to make sure you've given the responsibility to somebody, okay? And then you can even tell somebody else, can you look for a defibrillator also? And find out who knows how to do BLS, or who is certified here in CPR, or who can do CPR, okay? With a child, you first of all, you are opening the airway. Absolutely, open the airway and look. Because if there is a foreign object, you can do the finger sweep, okay? Just try and nicely finger sweep to dislodge it. We never try and pull it out with our 2 fingers. Do the finger sweep and take the object out. Usually, if this is the cause, then the child will start coughing. You roll them on the side, give them a couple of gentle pats on their back, and then you will not need to do CPR, okay? But what if it's an unfortunate drowning incident, or maybe in smoke inhalation, okay? You want to follow the steps of look, listen, and feel. All right, so you want to level with the child's belly. You're looking for the stomach going in this manner, 1, 2, 3, okay? Then you're listening for the breath of the child on your cheek, and then maybe you want to just feel for the carotid pulse also. All right, now the thing is, with a child also, it depends on their age. A neonate, or a child who is less than 1 month, it's a neonate. A neonate is less than 1 month. A small baby, you want to hold them in this manner. Cradle them on your arm, and please do not make this child fall. Some teaching sessions have had the child just go whoop, and the child just falls to the ground, and everybody's just like, oh gosh, you dropped the baby. A larger child, you can put them on the ground this way. And also the positioning of the hands is a bit different for each. But all you have to start with 5 rescue breaths. The 5 breaths should be a duration of 1 second. So 1, 2, and you're looking for the chest rise also. Say you're doing this teaching and Dr. James is busy chewing air burgers in the corner. You have to say, James, please, can you just pay attention? This is important for you to know, okay? And so you have to also watch your audience. So you're not just busy, so engrossed, and people have left the class and you don't know what's going on. Make sure that they're paying attention, okay? You put in the 5 rescue breaths, and then you immediately start your 15 chest compressions. Now, if you're 2 people, then it becomes a 15-2 ratio. If you are alone with a pediatric patient, you have to do the 32. Okay, so there's a big thing, and there was a bit of a confusion even in the pediatric clinic, with people saying, oh, no, it's supposed to be 15-2 if you're by yourself, and 32 if you're by, no. And there's also information on the NHS that says 32. NHS information is mostly even for the public, so they're trying to even help you give the most compressions before help comes. If you're alone, do 30 compressions and then give 2 breaths. If you are 2 people who are BLS certified in pediatrics, then you do 15-2, switch 15-2, 15-2, 15-2. Why? Because you want the most energy in all those compressions, especially with a child, okay? And then now what happens after this? This is the positioning. The positioning of the fingers is very, very important. Lower sternum should be depressed by at least 1/3 the AP diameter of the chest, or by 4 centimeters for the infant and 5 centimeters for the child. If you're teaching people and they don't know these metrics, I just use my fingers. I say, this is 1 centimeter, 2 centimeters, 3 centimeters, 4 centimeters. That's the rate, that's the depth of the compression. You don't want to go super deep. And when you're compressing, wait for the recoil also. A neonate can be compressed in 2 different ways, this way and also this way with the thumbs. Just make sure that there is that type of recoil also. The one who is a bigger child, you know, maybe a little bit of a toddler, then you want to use the heel of your hand, okay? The elbow has to be locked, the elbow joint has to be locked, the wrist joint has to be locked, and you have to go nice and straight into the ground, into the chest of the baby, watching for the recoil also. At what rate? At around a rate of more than 110 to 120 per minute. So 1, 2, 3, 4, 5, 6, 7. Okay. At this point, you may want your students to practice, okay? So if there are 3, 4 people, just say, anybody feeling brave enough to just come and do a couple of compressions here? Yes, they'll do maybe a couple of, you know, compressions, make it look a little bit awkward, teach them. But you want to keep it engaged, okay? You want to keep the session engaged with whoever you're teaching. Please, please, please. Then you continue. When do you stop? You keep going until you feel fatigued, because you don't want to pass out and now there'll be an unresponsive man on the floor and an unresponsive doctor. You have to stop if you're getting fatigued, because you might also end up with a heart attack. Another reason why you stop, and this is for CPR or adult CPR, is if the ambulance comes or if the person wakes up, okay? So those are the little tidbits with pediatric BLS. Adult BLS is not too bad. Pediatric is what people have the problem. Oh, good. resus.org.uk is one of the best resources you can go for resuscitation guidelines. Please, it's a very good thing to have even on your phone. And then here's the general NHS. It says a baby resuscitating a baby. Here you go. Avoid compressing the stomach is a good thing to know. Push down 4 centimeters or 5 centimeters in a child. Release the pressure then rapidly, about 100 to 120. So it is fast, okay? Then tilt the head, lift the chin, and give 2 effective breaths. That's very important. So you want to do that, tilt the head. So you walk in, the baby's unresponsive, check the mouth, tilt the head, lift the chin, give your 5 breaths, okay? 5 good breaths. Remember, when you are working, you always have to have the one way, like the mouth protector. So your lips are never going to go on top of that child, okay? or on top of that adult. Always have that protective barrier. They should be all around the hospital, all around the floors, on the tables, and all these things, okay? Good. And this is now the pediatric BLS algorithm that I had over here. So good. Unresponsive, call 911. Of course, is for America. No pulse. You have to start. You have to start your compression. When the AED arrives, you have to assess for the shockable rhythm and then follow the steps. Please look up defibrillation, because it's getting a bit with the way things are going in the NHS hospital. You might find a session where you have to teach some defibrillation techniques to your fellow doctors. Good. Child with asthma. A 3-year-old asthmatic, non-asthmatic, has frequent admissions. This is very, very frequent, especially in this country where it's cold 90% of the year, okay? A lot of allergies coming back. You will deal with many patients whose parents do not know how to use medications, or maybe their initial encounter with a doctor did not focus too much. So say you are in a pediatric ward, and you know, Johnny was admitted 2 weeks ago. He's here again. You know, you're looking at the records. The last 1 year, Johnny has had, almost 7 admissions. You have to find out what is going on. So speak to the mother. Okay. So you go in. Hello, my name is Dr. X. Are you Samantha Jones? Yes. And you're Johnny's mom? Yes, I am. How old is he? He's 3 years old. Samantha, I can see from the record that he's been with us for quite a, on and off for a couple of times. I'm really sorry. It's quite challenging to have a child who's sick so many times. How are you coping with this? Doctor, I'm really having a bit of a challenge with my child. I do the best that I can, but they just seem to be having a hard time. When was the asthma diagnosed? Here we go. History, past, present, future. When was the asthma diagnosed? How many attacks have they had? What are the duration of the symptoms, of course? Hospitalizations, she'll tell you. Go exactly to trigger factors. You want to get a short history. Okay, get a short history about the asthma. First about the asthma, because this is what is causing the frequent admissions. Okay, the asthma is causing the frequent admissions. Let me find out. There are a couple of things that could be causing his frequent admissions. Number one, medications. Are you giving him the medications appropriately? Yes. What medications is he on? He's on the blue inhaler and he's on the red inhaler. Do you have them with you? Yes, doctor, I do. Because he's a 3-year-old, he has to use these medications with an aero chamber. Good, I almost forgot that. He has to use it with an aero chamber. Do you have an aero chamber at home? Doctor, what is that? I don't know. Let me see if we have an aero chamber here, or let me give you a couple I'll give you a leaflet with the aero chambers that are needed for every child who has asthma, okay? A child who is the age of 0 to 1 needs the orange one. That's why I made it this way. The orange color, the yellow color, and the blue color. The 3-year-old is ranging between 1 to 5, so they need to use the yellow chamber, and the blue chamber, aero chamber. The blue chambered one is the, for the 5-year-old plus. So people get confused about the chambers we use for our asthmatic pediatrics. Okay, 0 has a big old O, so think 0 orange. And 0 to 1, they are going to use the small one, okay? From age 1, they use the yellow one. So yellow has 2 long legs, so that's how I remember it. And they can use this yellow one until they reach the age of 5. At 5, they have to switch and use the blue one. And then they can continue with the blue one until maybe they're an adult and they can just put the inhaler in their mouth and just use it. Very important for you to find out if our parents have aero chambers for their child who have asthmatics, and not just any color, it has a very specific color, okay? Good. So you find out the blue inhaler, you know what it's for. The blue one is a reliever. I always think of blue as, you know, the blue skies is going to relieve the symptoms, you know, and the red one or the brown one is the preventer. Why you need to know which one is which is because the preventer is a steroid. And the steroid one, if the residue remains in the mouth of the child, you may see some white coating also, which is a fungal infection that needs to be treated. So every time you use the blue inhaler and the red inhaler, have your child drink something like some juice or some milk. That way their, you know, their mouth is not going to be coated with that much medication afterwards. Can I please demonstrate how we use inhalers? Yes, doctor. Or you can say, can you please demonstrate how you use your inhalers at home? Okay. Frequent admissions has to be a problem, either the trigger factors or non-compliance. So you start with the big one, compliance of meds and using of inhalers. Please, please, please. So she'll take the inhaler, she'll turn it around and say, this is how I use it. Of course, maybe it may be the wrong technique. You want to tell her, if this is the inhaler, you want to position it in a specific way with the valve on the top. So the valve has to be at the top so that when you hook it up to your child's mouth, you see the valve moving up and down, showing that there is exchange between the atmosphere and the lungs of your child. So you always want there to be that part, okay? Your child is 3 years old. They might be a bit fussy when it comes to inhaler time. So make inhaler time fun time, Samantha. Put some music in the room, okay? Or your child's favorite cartoon, or give them their favorite toy. Distract them. Hold them in your arm, rock them a little bit, and then shake the first inhaler. You can use the blue one first, remember? Shake the inhaler. You're supposed to shake it for a couple of reasons: to mix the medication, okay? And also to estimate how much is left. Always make sure you also check the expiration date, okay? Attach the inhaler into the chamber, and then let the child breathe. Let the child breathe in a couple of times, rock them up and down. If they start to cry, unfortunately, they have to cry through the whole administration of the medication. And this is good because it opens up the lungs. So I'm sorry, you may just have to, just to persevere through their sorrows. Okay. Then give them a little bit of a break from the inhaler. Okay. Put some stickers, maybe even on the aero chamber, so they can associate it with a good thing. It's happy time. Inhaler time is fun time. Okay. Then choose the second inhaler. Oh gosh. Get the red inhaler, hook it up the same way, shake it up, give it to them. And then afterwards, make sure they have something to drink so that their mouth does not have the thrush. Can you demonstrate that to me? Because there's no point of teaching if you're not going to have a return demonstration. You see, that's why I said the history has to be very short, because you need to get understanding, okay? And then after she does it the right way, say, that is really good. I can give you a leaflet with step-by-step pictures showing what to do. Just in case you forget, put it on the fridge. Another thing that can make, frequent admissions in an asthmatic child is trigger factors in the home. Do you have any pets? Yes, we have Bobo, Dodo, and Coco the cats. All right, do you have a carpet? Yes, we do. How about plants in the home? We do, but I've put them outside. That's good, because pollen also kind of, makes the air a little bit thick with all these particles, and this can cause the triggers. Now, the worst thing you can ever tell a family is to get rid of their cats, their dogs, or their parrots, or whatever mice they have. Leave them with their animals. What do you do for them? You say, okay, if you have 3 dogs, then you may need to just shampoo them frequently, okay? Vacuum the house a little bit often if you have a carpet. We never tell a patient to go and make a wooden floor. Or no, you need to change the carpet, get wooden floors. The dogs need to be put up for adoption or need to be put down. No. Please. You can even say there are some specific products you can buy in the pet stores that help with defarring the animal or preventing a lot of fur from falling out. And there are some really good carpet agents that really prevent the carpet fibers from really, I wanted to say embolizing in the air, being released into the air. Okay, so those are the two things. And then in the end, you want to just make sure you tell her, please watch for a few more things that can cause exacerbations with asthmatics: extreme changes of weather. So if you're going out and the weather is a little bit chilly, cover this area. Get him a little bit of a windbreaker so he's not breathing in direct cold air. Okay, medications is important for you to keep, especially if he's at home and he's at school. Keep an aero chamber in the school and keep one at home. Make sure he has enough inhalers also. We hope that everything will be okay. I'll make sure that, we can review his lab work, check if he has any infection markers at all. Okay, sometimes the doctor may decide to give him some steroid medications to reduce the inflammation that has been caused with the asthma. So here you go. How to use your meter dose spacer. You shake the med, insert it into the mouthpiece. Okay, then breathe out with all your lungs. Now this is the thing. This is a kid. A 3-year-old, you can't tell them breathe out everything and then no, it's not going to work that way. All right. And then I have just a little bit of asthma drug therapy, just in case you have to talk about it to the patient. What is a reliever? It's a type of medication. It's a SABA. Okay. Then you have controllers, which are some LABAs. And then you have your preventers, which are your inhaled corticosteroids. So this is a nice little chart for you to get just to update some of the knowledge. Okay. Good. Remember the colors. The small orange one, 0, 0 here. Yellow, 1 to 5, and then blue 5. At least 5 has 4 letters, blue has 4 letters. They need 2 aero chambers, 1 in the home, 1 in the school. Okay, let's get back to counseling of patients. Now, because this country, like America, is getting very, very, very high rates of obesity. I don't know, the last percentages I saw were quite alarming, and mostly in children now. So, it's kind of sad. It's the diet that we're using. But believe, if you're going to be working in a GP clinic, 2 times a week, you may see a patient who is struggling with their weight. So, of course, you have to be compassionate because they are struggling not only physically, but also psychologically. So most of them may need some talk therapy to be able to find out what is going on, Samantha. What's going on? Okay. So you go in. This patient has come in with concerns to the GP clinic. Hello, my name is Dr. X, and I'm one of the juniors here. Samantha, how are you doing today? Well, doctor, it's my 40th birthday, and I decided to turn over a new leaf. Happy birthday, Samantha. 40 is quite a lovely age to be. Okay. What brings you to the GP's clinic today? Well, I've heard that the NHS can pay for a surgery for me to lose weight. Okay. Have you been struggling with the weight for a long time? Well, doctor, I've been, quite big for most of my life. If she throws a curveball at you and says, am I fat? Even the anorexics, they may say, doctor, am I skinny? You have to say, unfortunately, those are terms we do not use to describe our patients. There is healthy weight and there are extremes. There could be unhealthy weight, which could be more than healthy, or even underweight, which is under the spectrum of being healthy. Okay, but don't get into the trap where the patient says, am I fat? And you're like, a little bit. You can lose a little bit, Samantha. Lose a little bit. Leave the pasta. Okay, so you want to find out, first of all, the past. Is this something new? Is this something that has been there for a while? Okay, she's been struggling. And you find out, how does this make you feel that, you've been really trying to lose weight, but you've been losing motivation, you've started and stopped the gym, okay, your diet is really not good. I'm having a hard time, doctor. It's really bad for me because there's a big stigma on people who are overweight. And it's unfortunate. It's because of ignorance, Samantha, that people judge one another in this country because of how we look, you know. Beauty is on the inside. Would I say that? Of course. Which patient wouldn't want such an encouragement from a doctor? Doctors are very rigid people, and we are notorious for being heartless. So if you have an opportunity to touch somebody's heart and make them feel value, you do it, okay? The world is cold, okay? So you say to them, all right, you've been having challenges. Can we just talk a little bit more? I want to get more details. What is your diet like on a day-to-day basis? I eat chips and fish and soda in the morning, 3 sausages and 4 eggs at lunchtime. And in the afternoon, I'm sitting in front of the TV with a big bag of popcorn and some ice cream. Okay, Samantha, that's have you ever, evaluated the amount of sweets that you're taking or the fatty foods? Well, doctor, really, it's quite, I just eat whatever I can. So now you have to then evaluate depression, because she's showing you like a loss of hope. And obesity can have the differentials for the obesity is number one, I would do is depression. How is your mood? Do you feel like you eat more when you're stressed? Do you feel like most of the time you're eating by yourself, or you don't like company when you're eating? Have you noticed any other problems like insomnia? So you go through your SIGI cups, your sleeplessness, loss of interest, your not guilty, I'll just say any regrets after you eat a heavy meal. Okay. And then now just a little, just to gauge if she's not depressed, then fine, move on to a hypothyroidism. Have you noticed that your skin is becoming a bit dry, a little rough? The hair texture is also changing. You're having constipation, or you're really not tolerable to any temperature changes. Okay, and then the next one I would also do is a PCOS, polycystic ovarian syndrome. You have to ask her, have you noticed any development of hair around the chin, on the chest, in the back? All right, how are your periods? Are they irregular? Okay, if they're irregular, you want to find out when the last one was. Does she have stretches where she's not having any period at all? That's PCOS. So hypothyroid, PCOS, depression. And then fantastic question to ask, what is the distribution of your weight gain? Is it around the waist area? Have you noticed it around the legs? Because sometimes some kidney problems and heart issues you can have an accumulation of what we know as edema in the leg area. Have you noticed any is the weight distributed around the neck area, cushions? Have you noticed any stretch marks around, mostly around the stomach? Okay, so it's very important. So even though she's coming and she wants to lose weight, you have to check, because the gym is not going to help hypothyroidism. Okay, so another thing is patients really resolve to doing other things to try and lose weight. You have to ask her, what specifically have you done to try and lose the weight? I'm going to the gym. Good job, Samantha. I'm taking some medications. Where did you get these pills from? I got them from the internet. Of course, medications that is not regulated, she has to stop. Any side effects like palpitation from these? I'm taking Slim Fast. Okay, you have to really check. And then family is important. Anyone in the family who is struggling with weight issues, also cholesterol problems. Okay, and then what do you do for a living? How is this affecting you? All right. And now you can acknowledge and say, Samantha, you've really tried. I can see evidence throughout your life that you've really tried to lose some weight. Sometimes it's important to get just an extra hand. This is where we come in. And you mentioned to me that you're interested in the NHS surgery. Never forget the concern of the patient. You have to deal with it before you start giving them your fabulous lifestyle changes. You say, I'd like to do your BMI. The BMI maybe comes back as 40, because a BMI more than 40, you can qualify for the NHS surgery, okay? Because this BMI is on the higher side. Normal range of weight is between 18.5 to 24.9. Okay, so BMI of 40 is on the higher side. Don't say she's morbidly obese. She can see that every time she sees herself in the mirror. So don't say it. Leave it alone. Okay, don't say the obvious. So you tell her the NHS surgery, BMI over 40, you can qualify. But qualifying is not enough, Samantha. We have to check if you are fit for surgery. So this will be determined by the surgical team. So they're usually gastrointestinal surgeon or like bariatric surgeons. Okay, they'll sit down with you, evaluate your lungs, your heart, your kidney, because it is quite a stressful surgery. Okay, also, so they have to see if you're fit for surgery, and sometimes they may recommend you lose a little bit of weight before you go in for surgery. If your BMI is between 35 and 40, and you have another medical condition like high blood pressure or diabetes, a condition that will benefit if you lose weight, then you can also qualify. Okay, so this is when the NHS surgery applies. But I would like you to be healthier in the long run. I want you to be healthy for the long run. Okay, so can I talk to you about a couple of things you can change? You're eating fish and chips and soda every single day. What about choosing Saturdays to be a day where you are having a healthy day? Okay, so maybe, Monday through Friday to start with, okay, you'll keep on with the fish and chips, okay? Then Saturday, try and bake at least 2 of the meals. Use proper good oil, like a good olive oil. All right. And then after 1 week, we can move it up to maybe 2 days a week where you are eating healthier. And then we can add in some exercise. I can have one of our physical therapists here just sit down with you briefly and tell you a couple of exercises you can do at home. There are some gyms that are associated with the communities where they have movements and, motivational classes. So you join other people who want to be healthy. You will see in the long run, you'll be able to keep up with the motivation. Okay. Now, the thing is where we make a mistake is we start talking about the type of surgery that will be done by the bariatric surgery. Oh, you can do the Roux-en-Y, the Bill-Roth 2, I don't know, the gastric bands and the runs. Leave it. Or the sleeve gastrectomy. No, just tell her she qualifies, but you want her to be healthy even after the surgery. This is a great start to a new life. You and all that compassion and encouragement. Yes, that's what the doctors need to do. We need to be more compassionate. Okay, we need to be more compassionate to our patients. And then you can say in this practice we have seen some patients have been started on Orlistat, which is a medication that prevents the absorption of fat from the intestines. I'll talk to the consultant and see if this is appropriate for you. Okay, so it's a great start for you, Samantha. Put it on your calendar that today is day 1 of you getting healthy, getting a healthier weight. And if I can, I think we do have some weight loss clinics in the community. I can look up their numbers, and there they will actually link you with somebody who is a motivator, okay, or an encourager. So they'll call you, wake you up, keep you on schedule, all right? And we are also going to keep you on schedule and see how everything works out for you, all right? Any troubles, any questions, please give us a call. I'll have the consultant now come in and take a look at you. It's also important for me just to make sure that everything is fine. I want to check your cholesterol levels, thyroid level, function tests. If we have an inkling that it might be caused by hormonal issues, we can send some FSH levels, LH levels, just to make sure that the gaining weight is not being caused by any other conditions. Boom. Make sure you do that. Another one to counsel, and I even say honestly, in my practice, I counsel everybody, whether you want to hear it or not. You are going to be counseled today. Everybody needs to get some counseling. Diabetes is big. on complications. So some people just think once they come to the hospital and they're told they are diabetic, that's it. Poof, they can disappear into the horizon and not come back again. So we do see people who come back after they've been diagnosed, and they're having complications. For example, eyesight problems, they're having tingling on their feet, they're having ulcers, foot ulcers also, they're having kidney problems. It's quite unfortunate. So let's say you're in the GP clinic and somebody comes in with this type of presentation. Hello, James. My name is Dr. X. I'm one of the juniors here. And you also have to observe, because some of them, may be having some glasses on. And then you can ask, are you having a trouble with your eyes? Well, doctor, I have been wearing these glasses, because I haven't been able to see that much, or I can see out of one of my eyes, but this eye looks like it's very cloudy. And so you say to him, can you please take off the glasses just for a second? I just want to examine your eye. And he takes off the eyes and you see a big old cataract. So you have to really assess the non-verbal cues of the patient. All right. So he's sitting there, maybe his gaze is off. So you're sitting right in front of him, but he's looking to the side. And you ask him, James, can you see me? Yes, doctor, I can see you. But I can see your gaze is off. Oh, doctor, I'm sorry, I can't see. When did this start? It started 2 years ago. I'm really sorry about this. Are you having trouble seeing an outline of people or just the whole person? Like before me, and if you're in the room with maybe a student or somebody else, can you see whoever is in this room? Can you see the books that are on the table? Not at all. Can you see my hand? No, I'm having a hard time, doctor. All right. Did any chance by any chance you injured your eyes? No. So you've been a diabetic for 14 years? Yes, doctor. What medications have you been taking? Well, I'm supposed to be taking insulin, but I ran out of it. Okay, how long ago? Like maybe about 3 months. I'm very sorry about this. Okay. So who is with you at home? Because now the thing is, you have to start getting to the social part of it. Why is this 85-year-old? He hasn't been coming to the hospital for 5 years. He's having eye problems, leg problems, urinary symptoms. He has wounds on his legs. Who is he living with? I live by myself. So how do you prepare your meals? How do you wash your clothes? How do you clean your home? Honestly, I just do what I can. Okay. At some point, I'll need to have one of our team members who is a social worker come in and sit with you, because we may need to just reorganize a couple of things to help you. You may need a carer in the home, especially to help you clean and cook. Maybe pick up some of your insulin from the pharmacy. Okay. Check your blood sugars. Do you check your blood sugars? No, I don't. So he's in trouble. He's in big trouble. You can't just send him home. And even this one, I would not even send home because he's having eye problems. I'd like him to see an ophthalmologist. Okay. So you can all cut all these symptoms. Eye problems when they started, is it both eye? Any injuries there? You can even ask if there's any symptoms of weakness on the side of the face, on the arm and the leg. Okay. Vitamin B2, because B12 I'd ask because he's having tingling, but it's really bad. He's really having a hard time. Okay. Then you would say to him, I would like to do, of course, check your vital signs and do a physical examination, especially to check and see the soles of your feet. And just to recap a few things about how to do a foot exam, any examination you want to do on a patient, you have to tell them the procedure. So P for procedure, E for exposure, okay, C for chaperone, and then another C for consent, and then U. If you're uncomfortable anytime during this procedure, please let me know. I would like to do the procedure. I would like to take a look at your legs, use a couple of instruments, tap around, okay, see if there's any swelling. I need you to expose from your mid-thigh all the way to the tips of your toes. That's your exposure. I'll have a chaperone if you want. Is it okay for me to proceed? Consent. And then if they're uncomfortable, please let me know. And then now, if there is a lab report, for example, it says that you want to do maybe a fundoscopy, and the fundoscopy is showing some changes in the back of the eye, maybe some cotton wool spots, which is usually one of the big ones with diabetes. Okay, then you tell him about the reports. And when you're talking to a patient, break down the information. We looked at the back of your eye, and we saw that you do have a bit of changes. They are concerning to me, so we'll have you see an eye specialist, because they may be able to help the progression of the damage to the back of the eye. I can also see that your reports have come back showing a very high blood sugar or a high HbA1c, meaning over the last 3 months, your blood sugar has not been well controlled. From today, we'll get a plan, get somebody to be shopping for you, get you back on your insulin, get you back on a good and healthy diet, all right? And then if kidney functions are off, like he has some nephropathy, then you tell him there also is some changes in your kidney, and we've noticed in your urine that there may be some infection. And it's usually... with diabetics, we have to be very vigilant of the amount of sugar in the urine, because sometimes these high contents of sugar in the urine, called glycosuria, can lead you to have a urinary tract infection. Okay, so we are going to keep you here, all right? Or we are going to, if this is a GP clinic, we don't admit, we are going to send you for an admission to the hospital, okay, where a diabetic doctor, an endocrinologist will follow up with you. They could have an ophthalmologist there who is also going to investigate what's going on with the eye. And also we'll start planning on how we can get you back to living a healthy life, okay? Do you know some of the symptoms of, high blood sugar, James? Yes, I do. Ask them. Some of them don't need you to tell them all this shaking, palpitation, sweating, nausea, blah, 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 all these things. No. The thing is with diabetes, it can put you at complications for heart disease. So this is why I need you to get managed. Okay. Do you have any family? No, I don't. Anyone around or in the neighboring towns? No, doctor, I'm all by myself. Okay, so we'll see, social services will really be able to help. And, if in the end we feel like it's really not safe for you to be at home, we may need to have you be in a community setting where, you'll be around people who can take care of you. Don't tell them you're going to send them to a nursing home. Please, not good. Another diabetes case you can find is maybe somebody who's driving a commercial vehicle, like a bus driver, a school bus driver who is having troubles with his, with his managing his diabetes. And because he's not compliant and he's passing out every time he's behind the wheel, he's putting the poor children at jeopardy, or he could be an Uber driver, a taxi driver. He could be, maybe one of these NHS transport workers, or an ambulance driver. The thing is, people who drive commercial vehicles are at a different category if they are having diseases that are reportable to the DVLA. So even before we talk about that, let's talk about this. There are notifiable conditions that have to be told to the DVLA about medical conditions or disabilities. Diabetes, or anybody taking insulin, people who are having syncope, fainting episodes, atrial fibrillation, and anyone with a pacemaker, they have to tell them. Sleep apnea or obstructive sleep apnea, anyone with epilepsy, TIAs and strokes, glaucomas, cataracts, anyone with macular degeneration, or anything that you think in your mind might need to notify the DVLA. Just think about it in those terms of safety. Okay, so a patient comes in and you realize, what do? I work as a school bus driver. Okay, James, the thing is, because you do a very important job in our community, and thank you for your service. Thank people for what they do, please. Okay, you may need to provide some medical documentation the next time you go to renew your license. Okay, I am here as your doctor to, ensure that you live a healthy lifestyle, a healthy life. That's my main focus for you, not to take away your license. No. So doctors, don't fight with people and the DVLA. If a patient says, I don't want to tell the DVLA because I have syncope or atrial fibrillation, tell them, no, by all means, I'm not here to make sure you lose your job. I want you to keep your job. I want you to continue being the best school bus driver. In fact, ask them, what's your bus route? How are the kids in the bus? But make a good rapport. That's how you make rapport, okay? You cannot say to them it's illegal for you to drive a bus or a blue lights, because the diabetes company of the UK says otherwise, okay? So diabetes will make you, Mr. Smith, just have to take a couple of more precautions, but you can continue doing the things that you love, okay? Now, the thing is, you have to tell the DVLA, and what the DVLA does is they will investigate and they may contact us to see whether you are fit to drive, or whether you've been coming for your, your eye exams or your foot exams. So that's where we come in. They may even have you take a driving test or an eyesight test. So what is my part in all this for you? I want to keep you healthy. Don't miss your ophthalmology appointments. Don't miss to take your insulin. Make sure you get your foot doctor to check your legs. Come in for your regular visits. Don't miss this. It's very important, because when you're renewing your license, they will take into consideration whether you have been compliant, okay? And sometimes you may have to temporarily hold off on driving until you are able to regain full function, or a considerable or safe amount of function of your hands, your legs, and your eyes. So don't fight with them, okay? DVLA is your friend. Good. I wanted to talk a little bit about OCPs because they are quite challenging, and then we can always continue about this tomorrow. So this is a very frequent thing again in the GP clinic. Somebody comes in asking for oral contraception. We just can't give it, okay? You have to make sure that you go through your checks. So you ask, hello, of course, your rapport now, you guys know how to do rapport. What is your main concern? I want oral contraception. Some of them come in with very specific demands. I want the IUD. You have to ask them, is there any specific reason why you want the IUD? Okay, this one is just saying, I just want oral contraception. All right. And what do you do when a patient just asks you that? They're not sick. Go to medical conditions. Do you have any medical conditions? Or when was the last time you came to the GP? They checked your blood pressure, your cholesterol, any diabetes? No. Okay. How about these conditions? Are they present in your family? How about any other conditions? Cancers, heart attacks, strokes? No. Okay. What do you do for a living? I work in the bank. Do you enjoy your job? It's great. Okay. So with every oral contraception, before we prescribe it, okay, we have to make sure that it's going to be safe for you. And there's a lot of types of contraception. You can't just start saying, we have condoms. Condoms are 95%, blah, 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 blah. We have IUD. IUD are 50%. We have this. This is this percent. You cannot bore the patient with the whole book of OCP. Ask them, are you interested in long-term contraception or short-term contraception? Or would you want an implant in the arm or an implant in the uterus? Okay, because there are these types. There are pills that you can take also. So what have you been thinking about over the past few days? And when are you planning with your partner to conceive a child? Or what are your plans for conception in the future? I don't want to be pregnant in about 5 years. Okay. So there is long-term contraception, but this one would involve implants. Oh, I don't want any implants. Okay, you can still take the pills for a long amount of time. Do you think you'll be able to remember to take a pill every day? Yes, doctor, I can. And if you have challenges in remembering, you can always put the pills next to, in the bathroom near your toothpaste. So when you're brushing your teeth, you can always get it there, or you can always set an alarm on the phone. All right. Now, if she says she wants the pills, then you start with the contraindications. Have you ever, first of all, it's so important to find out about the job, because flight attendants, long flights from here to Australia, smokers, these ones you have to be able to pick. So you have to really ask history of any clots, liver disease. Okay, smoking is very, very big. And my favorite one is migraines. Many people don't understand migraines. It's very surprisingly. You ask them, how about migraines? Maybe I don't think so. How about any headaches? Well, I do have some headaches. Sometimes they immobilize me and I have to, switch off the lights and stay in a dark room. Oh, maybe you have an undiagnosed migraine. I'll need to set up another appointment for you to come in. But please, break it down. We have two types. There's long-term, short-term. There are medications, there are devices, the devices in the womb, there are devices in the arm, okay? And even according to your menstrual period, if you have a heavy period, some devices that are implanted in the womb may not be appropriate for you. So you don't have time to talk about everything. Honestly, really try and break it down easy. If you find out any contraindication, then you can't offer that. You have to move to the next thing. So if she says she wants pills, then I'll start with the estrogen progesterone. Tell her this one is a 2-hormone pill. Okay. But then if you had any clots in the family, we'd have to stop on this one and then move on to progesterone only. Okay. Progesterone only will prevent ovulation, or it will cause a heavy mucus on the cervix. So now the semen cannot pass through and fertilize the egg. A few things with these meds, you always have to give side effects. So they're not blinded, okay? They're not blinded about it. Weight gain, irregular periods, headaches, okay? And you have to take them at the same time daily. They don't have to decide on the same day. You can ask her, are you sexually active now? Yes. Are you using any preventative method to prevent pregnancy? Yes. What are you using? I'm using condoms. It's important, even while you're on the pill, to consider prevention of sexually transmitted infections. And this is usually done by using the barrier method, which is the condoms. All right. So you don't have to decide now. Continue using the barrier method. I can give you some documentation or some printout from some of our books here. Think about it. You can always come back in the next 1 or 2 weeks. And then if you have questions, we can sit down and talk about it. And I'll invite my consultant also to be part of the conversation that way. If she picks one, you have to tell her, especially for the combined, you have to tell her, it's good that you do not smoke. Please do not try smoking while you're on this medication. The risks of blood clots and oral contraceptives is very high. Also, if you're going to have any long flights, it's important to walk around the plane to avoid blood pooling in the legs. Or, while you're in the plane, you can just do a couple of exercises just to keep the blood moving. And it's important for me to tell you, Samantha Jones, that there's no contraception that is 100% except abstinence. Okay. And so if you notice some bloating, or you're having some mood changes, nausea, vomiting, weight gain, you'll need to check a pregnancy test. Okay. You can always come back here and we can check it for you also. All right. And then, we can take it from there. Then now the thing is, what else can she ask? Well, she can ask you, if I need to come back and get some prescriptions from you, doctor, is it okay? Usually you can send the prescriptions to the pharmacy. So once you're done with the medication, then you can always pick up the prescription from the pharmacy. But if you have any other concerns, and watch, if you're having any pain in the legs at all, you need to come back to the hospital for us to take a look at you. Okay, have I gone above our time? That's really quite interesting. We shall continue again tomorrow. Let me see, continue studying hard and practicing. Let's see here. I have pause.